It is still connecting, sir. Just wait, please. So in 3, 2, 1, we are live.
Dr. Nanda, you can start, sir.
Yeah. Hello. Good evening, everybody. I'm Dr. Vijay Nanda, speaking from Premier Gastroenterology Institute, Jalandhar, along with my colleagues, Dr. Amit Singhal and Dr. Alok Sehgal. I welcome all of you to this Gastrocon 2021. It is being arranged under the aegis of Punjab chapter of Indian Society of Gastroenterology. We have arranged for you 4 very interesting lectures which are to be delivered by very eminent speakers, and it will be followed by a panel discussion on management of Helicobacter pylori infection. I hope you will all enjoy this very much, this academic feast. At the outset, I want to thank all the speakers, the chairpersons, moderators for participating in the event. I will briefly, before starting the lectures, introduce all the chairpersons and moderators. First is Dr. Harpreet. Dr. Harpreet Singh is a very senior gastroenterologist. He is from Amritsar. He is running a big institute over there. And currently he is president of the Punjab chapter of Indian Society of Gastroenterology. Dr. Mohit Nanda, he is from Jalandhar. He is director of a multi-speciality hospital called Mannat Hospital, and he is currently president of the Digestive Disease Forum in Jalandhar. Dr. Varun Gupta is a brilliant and young gastroenterologist who is working in Patel Hospital, Jalandhar. Dr. M.K. Arora, he is the senior most gastroenterologist in Jalandhar, and he is also chief of M.K. Hospital. Dr. Nitin Arora is a senior physician in Jalandhar, and he is working in Sacred Heart Hospital. He is also president of the Physician Forum in Jalandhar. With this, before starting the lectures proper, I would request Dr. Harpreet Singh to speak a few words as president of the Punjab chapter of Indian Society of Gastroenterology.
Dr. Harpreet, I think he has not joined yet. So we can start with the lecture.
Start with the lectures. We will take all these lectures, 4 lectures, one after another, and discussion and question answer session we will keep at the end. So first I will request for the first lecture Dr. Siddharth Shrivastava. He is professor of gastroenterology at prestigious GB Pant Hospital, New Delhi. He will be speaking on management of acute pancreatitis. The time allotted for each lecture is around 20 minutes. Professor Shrivastava, please. if Professor Siddhartha is
Sir,
not around.
he's sharing his screen, sir. Just a minute, sir.
Right, right.
Hello, Dr. Nanda.
Yes, sir.
Harpreet
Dr.
Singh here.
Harpreet Singh speaking.
Yeah. Good evening, sir. I
Yeah,
joined you.
you can speak for a few minutes
Yeah.
right now.
Thank you very much. Yes, thanks a lot. Yeah.
Yeah, you can start.
I, on behalf of ISG Punjab chapter, I welcome all the delegates and the speakers on this auspicious day for a very prestigious CME be conducted by Dr. Vijayananda and his team. I congratulate all his team and Dr. Vijayananda. They have taken again a lead in conducting this, CME after a long gap. And we are meeting after a total of 1 year. Exactly on this day, we met in Jalandhar physically. But because of the COVID, this pandemic, we have not been able to conduct any session in the last 1 year. I hope this pandemic will go soon and we will be able to conduct more and more such CMEs in future with the help of Dr. Vijayananda and our other senior colleagues. I now switch on, hand over my mic to Dr. Vijayananda, which he has already started his proceedings. I'm sorry for the delay, which I was stuck on
No
the
problem,
road show.
no problem.
Okay.
Thank you very
Thank
much,
you very
sir.
much.
Thank you very much. And we
Thank
start
you.
with the first lecture.
My
now.
pleasure. My pleasure.
Thank,
My great wishes for all this show to you. Okay.
thank you, sir. Thank you.
Siddharth,
My
sir,
pleasure.
you can try to share your screen once, sir,
I
please.
can. I'm just trying to do that.
Yeah. How can I help, sir?
I'm just trying to do that. Yeah.
Yes, we can see the screen, sir. Perfect. And we can go on a slideshow, sir.
Yeah. Sure. Sorry for the delay because there was some technical glitch. I don't understand what it is. Thanks a lot, Nanda sir, for such a kind introduction. Thanks, Punjab chapter of ISG, for inviting me for this presentation. I'm really delighted to have an opportunity to speak in front of you all August gathering. Today, we will be speaking about the management of acute pancreatitis. So as far as pancreatitis is concerned, pancreatitis basically is divided into two major subgroups. One is the milder form and the other one is the severe form. So mild acute pancreatitis does not require much of an intervention. It might even not require admission. So major problem is severe acute pancreatitis or moderately severe acute pancreatitis, where we need to intervene. And as a gastroenterologist, what we all need to know, and as a physician, when we should understand that the patient is has to be referred to a specialized center, we should understand before making treatment a real important for the patient. I'm just sharing this slide for what we had about 2,500 admissions in our gastroenterology department, out of which about 15% are acute pancreatitis. Acute pancreatitis is one of the few emergencies which bothers almost each and every gastroenterologist. Of all the pancreatitis subgroup, only around 20% is severe acute pancreatitis, and here the problem arises of the mortality. Now I will just show you this famous 2004 very elucid way of presenting how the acute pancreatitis works. So there are two definite phases of acute pancreatitis, one which is occurring within the hours and within the first week. Second week is usually quiescent, and the late onset, which is third and the fourth week, from the onset of the pain. See, all the definitions of the pancreatitis are basically zoomed at onset of the pain. From onset of the pain, within hours or within the first week, it is a very difficult time. There is a cytokine storm, there is trouble. Whereas in the late phase, which is usually in the third and the fourth week, the mortality again rises. Over the middle intervening phase, mortality usually remains very stable and patient is more or less stable over this time. Just look at the mortality in the early first week, where it is close to 30%, and look at the fourth week mortality. Again, it is close to 40%. So if we are able to manage mortality within the first week and the fourth week, possibly we are taking care of 2/3 of the patients. Now, the problem with the first week mortality is this is initiation of the cascade, which is called as an inflammatory cascade. And here, majority of the drugs have been tried. At least 40 drugs have been tried, like lexiprophen, gabaxate, and so on and so forth. But nothing works here. Even interferon is being used in some centers. But mortality in this subgroup is basically dependent on how the patient well is managed in the intensive care unit. Whereas if you look at the fourth week mortality, it is basically because of the infection, which is because of the necrotizing pancreatitis. There is a collection, and which leads to secondary infection. My talk will largely be dependent on this fourth week mortality, because in the early or the first week mortality, usually gastroenterologist or as a physician, we look into intensive care unit where the patient can be managed. Now, if you look at the Atlanta 2012, which is revised Atlanta classification, which is being used now widely for almost everything, everything is divided into two subgroups, which is called as an interstitial and necrotizing pancreatitis. Interstitial pancreatitis is one where necrosis is almost negligible, and this includes both pancreatic as well as extra pancreatic necrosis we are talking about. In earlier Atlanta classification, it was mainly because the interstitial, pancreatic necrosis which we were taking care of. But in revised classification, it is more of both pancreatic as well as extra pancreatic infection. Both are divided into subgroups of less than 4 weeks and more than 4 weeks acute pancreatic fluid collection, which may transform into pseudocyst, which is a rarity nowadays. And in necrotizing pancreatitis, it is usually acute necrotic collection and walled-off necrosis. Walled-off necrosis was a recent terminology which was coined in the Atlanta 2012 classification system. Now, these are some photographs which are shown to this the classify these things. They are, the first one is showing acute pancreatic fluid collection, where you can see this black colored thing around the pancreas. This is the pancreatic fluid collection. This might transform into what is called as a pseudocyst. Similarly, necrosis here, the pancreas. If you look at the pancreas here, it is very well enhancing. If you look at the pancreas here, the pancreas is almost non-existent, and it is called as an acute necrotic collection. And this will transform into what is called as a walled-off necrosis. So the second important concept is when ERCP is to be done in a biliary acute pancreatitis. The concepts are pretty simple and clear, that urgent ERCP is required in a cases of cholangitis. Within 72 hours, if there is an evidence of a biliary obstruction based on an ultrasound or MRCP finding, and if both of them are not there, then no ERCP is required. It might worsen the course of acute pancreatitis. Now, when to intervene? In patients who are having infection, which is called as an infected necrosis, again, it is to emphasize that within the first couple of weeks, the SIRS is there, which means there is tachycardia, there is tachypnea, there is like leukocytosis, there is fever, but this not translate into what is called as an infection. Infection occurs usually during the late course of the acute pancreatitis, during the third and the fourth week of the onset of the acute pancreatitis. So during the initial couple of weeks, do not look at the infective component. Usually it occurs towards the latter part of the disease. What is clinically suspected infected pancreatic necrosis? It means that persistence of SIRS beyond third or fourth week of the illness, or initially patient was not having SIRS, now patient has started developing SIRS. Organ compression, whereby cyst is compressing upon the stomach or the duodenum or into the vascular component. Abdominal compartment syndrome has been very beautifully defined in a paper way back in 2006, where the pressure of the abdominal compartment was defined, and anything which is less than 9 centimeter of water was considered normal, and anything which was more than 15 was considered abnormal, and anything more than 20 was considered as abdominal compartment syndrome. Now, another important indication is a persistent pain. Persistent pain is, as we define now, is by the requirement of analgesics. Occasional requirement analgesic is not taken as an indication for drainage, but continuous requirement of analgesics, especially the NSAIDs, and if it is required in the parenteral doses, then it is always considered as an indication for drainage. And third, most important thing which we have found in our study is failure to thrive, where patient is unable to gain weight, where patient is persistently unable to take food to meet his basic BMR. Now there has been a paradigm shift. If you look at it in the history, before 1990, it was purely surgery. Surgery, why? Because that was considered to be sine qua non with the management of the pancreatitis. But remember that the surgery here carries a very high risk of mortality, which was close to 50 to 60%, and a very high rate of mortality, morbidity also. The pancreatic fistulas which were forming after the surgical procedures were close to 30 to 35%. The management was boomed by what is called as a percutaneous drainage, where ultrasonic or CT guided drainage was done, and it started way back in 1990. And this changed the management lot from surgical to minimal intervention technologies. But even the percutaneous drainage did not give the desired result. The rate of fistulas, which is assumed to be a morbidity, was still very high. It was close to 37 to 40% in various cities. 2007 marked the era of endoscopic drainage. Endoscopic drainage, whereby you create a fistula between the cyst cavity and the lumen, whether it is a stomach or it is in the duodenum. It revolutionized the treatment of walled-off necrosis or any collection which is getting infected. So if you look at all the three subgroups separately, surgery is the most radical treatment. Problem is very high mortality and morbidity. There's a long-term complications, especially in the form of a persistent fistula, which keeps on draining. Percutaneous, the issue is pretty simple, but the only problem is that it requires admission of the patient for a pretty long time. It requires upgradation of the catheters over the long time, and there is a persistent external fistula close to 30%. And the problem if we do not use endoscopic, percutaneous endoscopic necrosectomy, what is called as, it cannot remove the large size debris. The other issue is that whenever there is worsening of the symptoms of the patient, you require imaging. And frequent imaging, especially in the form of the CT, increase the risk of radiation hazard to the patient. Endoscopic drainage, initially we were draining almost everything with a plastic stent, multiple plastic stent. No external catheter is there. And initially, if it was done by endoscopic techniques, then if collection is not very close to the lumen, it cannot be done. Technical expertise is needed, which occurs with almost every procedure whenever you start with. And in case of debris, it is suboptimal drainage, and initial results are not very encouraging. So we, as a gastroenterologist, our main aim is for the endoscopic drainage in transmural access, whether conventional, which is ERCP guided drainage, or EUS, where we do endoscopic ultrasound guided drainage. Technical success rate is no difference. Clinical success rate is more if you do it ERCP wise, and complication wise, there is no significant difference. It is about the initial trials we are talking of. And over the latter years, the technical success rate has gone up to 100% or more than 90% in both EUS guided drainage as well as the conventional drainages also. But problem is, if it is a non-EUS group, complication rate is slightly higher as compared to EUS group. Now, once you have decided about the endoscopic drainage, which stent is to be used, As far as European Society of GI Endoscopy is considered, they recommend both plastic as well as lamps for the first drainage. Problem with the lamps is long-term data on the lamps is lacking. And if we look at the comparative study between the lamps as well as plastic stent, clinical success rate was much higher for the lamps. And plastic stent, the problem is that the multiple plastic stents are required, which might result in higher degree of complications. The one which I think has revolutionized the treatment of the pancreatic one is EUS guided SEMS placement. These are the lumen opposing stents. First time introduced in 2010. And what we are using is the Nagi stent. We do not have other stents like Plumber, the Axios, and so on and so forth. But presently, Nagi stent is presently available, and it is not that costly as compared to Axios. Axios costs about 1 to 1.5 lakhs. Nagi stent is close to 30 to 40,000 bucks. Now, why EUS guided SEMS placement? The most important thing is that if you look at the lumen of the EUS guided SEMS, it is about 1.6 centimeters. Think of percutaneous drainage where we are talking of 10, 12, 14, 16, and 20 French. 20 French essentially means it is about 6 to 7 millimeters. Here we are talking of a lumen which is about 1.6 centimeters. This drains most of the debris. And as we know that the endoscopes usually range from size from 9 to 12 millimeter, endoscope can easily be passed through this stent. And if there is a large debris or clot, you can remove it and take care of the necrosectomy part as well. The only problem is that the equipment is costly. Most of the scopes are costing more than 1 CR. It is technically demanding, and there is no head-to-head trial with either the percutaneous drainage or with the surgical management. So I will just show you this short video about how we do at the Nagi stent placement in our setup. Here we go. Just we have identified the non-avascular area in the cyst. This is a large wall of necrosis. We pass the guide wire. Once we pass the guide wire, we remove the catheter from which we dilate, and then we replace it with a balloon. Balloon usually we are using is of 10 millimeter caliber. Once we dilate this balloon, then we place the Nagi stent. You have to remember this yellow mark is very important while we are placing the Nagi stent. It has to be approximately 2 centimeters away from the gastric lumen. Once you place the stent successfully, you can see the amount of fluid which gushes out. You are very happy that, okay, there's a fluid and this all has been removed. But this is not the case. What happens that there is a lot of necrotic material after this fluid debris. And for this, people have used a lot of nasocystic drains. We are not in favor of using nasocystic drains because it creates a lot of discomfort to the patient. We prefer to do more of necrosectomy rather than putting these catheters. You put a nasocystic drain, which is usually a 7 French catheter, and you drain it daily with 500 to 1000 ml of saline, which is mixed with some of the antibiotics, whether it's bacitracin or hydrogen peroxide or something. Now, the problem with the hydrogen peroxide is it causes literally avulsion of the vessels and it leads to more bleeding. Clinical success, I don't find there is much of a difference, and no difference with or without nasocystic catheters. Now, need for necrosectomy, which we believe is more important than putting in a nasocystic drain. If the size of one increases, then the need for necrosectomy also increases. Another clinical parameter is the persistent organ failure and multi-organ failure, along with high values of CRP and extent of necrosis. These all lead to tell you that there will be a more likelihood of necrosectomy. This is how we do necrosectomies. So if this was a stent which we placed earlier, as I showed you in the last video, and if you look at this black colored material, it is a necrotic material. As I put my basket across this necrotic material, you will see there's a gush of pus which comes out of the stent. So once you remove this whole necrotic material, then the chances of drainage are much more. and chances of improvement of the patients are improvement of the patient is much more. So we can remove as much necrotic material as possible, leaving the healthy granulation tissue behind so that the cavity heals from within. So if I compare it with video assisted retroperitoneal dissection, morbidity and mortality are very high as compared to our endoscopic necrosectomy, and organ failure is again very high in surgical subgroup. Mortality in our subgroup is also very high, very reasonable, 10% as compared to 40% in surgical group. If you look at, as you compare with the PCD group, there is clinical resolution with in more than 90%, and it requires shorter hospital stay. If you do retroperitoneal necrosectomy, which is usually done with an nephroscope, the success rate is similar, but hospital rate is much more lesser in endoscopic subgroup as compared to retroperitoneal necrosectomy. And if you look at the open necrosectomy, literally there is no comparison, because open necrosectomy is a major surgical procedure. We should not compare it with the endoscopic one. So what we have learned over last a decade, that endoscopic step-up approaches are much better as compared to percutaneous step-up procedures, and dual approach, drainage approach is feasible, and it is worth doing in few of the patients. The most important thing is to advisable to delay the first intervention as late as possible. At least on CT, you should see that there is formation of a wall, then only you should intervene, or at least 4 weeks from the onset of the pancreatitis, you should wait before you go for subgroup. This is a Lancet study in 2017 where they went with endoscopic step up versus surgical step up. Surgical step up means percutaneous drainage followed by surgery, and you look at number of drainage procedures, pancreatic fistula, and hospital stay are all very low as compared to the surgical step up group subgroup. But the problem with this Dutch study was that they have used only plastic stents. They have not used metallic stents for comparison with surgical step-up approach, which to my mind is a major drawback. Now let's look at the complications of endoscopic necrosectomy. Most important is bleeding followed by perforation, stent migration, and pancreatic fistula. To our experience, bleeding happens to be the most common. This, I'm sharing a patient which we recently did. You look at our last pseudoaneurysm arising from the splenic artery. Again, this was coiled under EOS guidance. This you can see is the needle, and this is the coil which we placed in the pseudoaneurysm. We placed two coils in the pseudoaneurysm, and one of the coils slipped into the splenic artery. And you look at this splenic artery, the upper end is totally infarcted and lower end is still viable. This is a coil inside the upper splenic artery, upper branch of the splenic artery, and this is the coil within the splenic artery pseudoaneurysm. This was a blessing in disguise, because this young lady was also having a non-cirrhotic portal fibrosis, NCPF, and she was having hypersplenism. And if you look at her parameters on day 0, TLC was 1400 with a platelet count of only 17,000. And if you look at day 14, she looks as normal as any person can be. Stent migration is another problem if we have put in up to 2 plastic stents. And the problem with here is now the cavity has collapsed. So there is hardly any space left in the cavity for stent removal. So how to do it? So what we do, like in this patient, we just passed in the guide wire into the cyst cavity, and then we dilated with a balloon, which is about 10 odd millimeters of the balloon. And once we have dilated the tract, you look at this waist of the balloon, this is completely removed, and then you can remove both the stents altogether. Now, what we follow at our institute is PCD, 10 to French, 12 French catheter, and every 7-day upgradation. And if patient becomes asymptomatic, then we go ahead with the discharge of the patient. And in the other subgroup, we go with SEMS, and under EOS guidance, And if the patient does not show a response within 72 hours, we go for necrosectomy. And once 4 weeks have passed and there is no symptoms in the patient, we do an ultrasound or a CT and look for the residual collection, and then we go ahead with the removal of the stent. What is our experience so far? We have included about 264 patients of the one, predominantly male. Most common indication was the pain, mostly was single collections, and size was more than 10 centimeter. And in our series, mortality was 13% only. Look at the mortality which we stocked initially all over the world is close to 40%. We were able to bring it down to 13%. This data is from 2019 till 2019. Beyond that, our data is now showing a mortality of only 8%. So we are gradually declining the mortality, whereby this is a recent publication which we did in for this study, whereby we went with endoscopic drainage in about 30%, percutaneous about 37%, and combined drainage also we did in about 10 patients. Only one patient required surgery. Remember that this algorithm, whereby the first treatment was surgical as a gold standard, now we only required one patient who underwent surgical intervention of the 264 patients. If you look at the baseline characteristic between endoscopic and percutaneous drainage, there's hardly any difference. Both the parameters are absolutely comparable. But if you look at the results, hospital stay is much, much less in endoscopic drainage arm. If you look at the complications, it is much lower in endoscopic drainage. Major complication which we define by bleed or migration of the stent occurred in all the 6 patients, and here it is almost comparable with the percutaneous drainage. Readmissions again were very much less in our endoscopic drainage, and mortality, look at the figures, is close to less than 5%, which is almost like an ideal situation. So to conclude, I will just suggest that severe acute pancreatitis is associated with a mortality close to 40%. Not all local complications need intervention. In our subgroup, the study which we published, close to 30% did not require any intervention. They all improved only with medical and conservative management. Managing in proper and stepwise approach lead to decrease in mortality. Changing approach is from surgery to minimal invasive therapies, and surgery still remains a salvage therapy. Thanks a lot for your patience hearing.
Thank you very much, Professor Srivastava, for an excellent lecture, for highlighting all the complications of acute pancreatitis and their management. To delegates, I will request that they can write all their questions and they can send them to the, yes, they can send it, they will be answered. We will move on to the second lecture with that. And second lecture is an approach to difficult CBD stones, which will be, the lecture will be given by Professor Gaurav Muktesh. He is assistant professor in the PGI Chandigarh in Department of Gastroenterology. So I will request Professor Gaurav Muktesh to deliver the lecture, please.
Hello. Good evening, everybody. Am I audible?
Yes, Gaurav, you are.
Yes, you are audible, sir.
Thank you, Dr. Amit. So to begin with, I would like to thank Dr. Amit, Dr. Nanda, and the entire team of Punjab ISG, which has given me this opportunity. I will be talking about the approach to difficult common bile duct stones today. So the outline of my talk would be the standard treatment for bile duct stone. What is the definition of a difficult bile duct stone? What are the factors that are associated with a difficult bile duct stone? And what are the different treatment strategies one can adopt for a difficult common bile duct stone? So as we all know, the main treatment modality for a bile duct stone is ERCP. What does ERCP stand for? ERCP is endoscopic retrograde cholangiopancreatography. You bring in a scope close to the papilla, you cannulate the bile duct, you take a cholangiogram, look at the stones that are visible, and then take a balloon sweep or use a balloon catheter to take out the stones. This is a papilla that is visible. One can see a cholangiogram with multiple filling defects. ERCP is used. Subsequently, a sphincterotomy is done to cut open the papilla, and then balloon sweep is done to deliver a large stone, as is visible in this image. So how successful are we when we're using standard ERCP techniques to take out stones? Standard sphincterotomy using an extraction balloon or a basket is successful in around 80% patients. However, another 10% patients may actually undergo a successful CBD stone extraction if a mechanical lithotripter is used, reaching to up to close to 90%. So now what we're talking about is a difficult CBD stone. 90% patients we can still manage with usual modalities, despite the fact that around 25% of patients they could require maybe 2 or maybe even more than 2 ERCPs. So what exactly is a difficult stone? The definition is very varied. Across literature, people have used different definitions and different cutoff, which actually tell us what exactly is a difficult CBD stone. First, it's a difficult altered anatomy. If one cannot gain entry into a bile duct, no matter what is the size or the shape of the stone is, one would label it as a difficult bile duct stone. Intrahepatic stones, which are difficult to be taken out by a gastroenterologist or even an interventional radiologist, stones above a stricture, which make them very difficult to take them out, and large bile duct stones. When I say a large bile duct stone, I can say maybe 1.5 centimeters to 2 centimeter stones are actually labeled as a difficult bile duct stones. So when I'm talking about challenging access to the bile duct, there can actually be a diverticulum, a periampullary diverticulum that makes access difficult. There can be an altered surgical anatomy. There can be ampullary or duodenal tumor mass. The duodenum can be scarred, which makes access into the bile duct very difficult for a ERCPist. There can be ampullary edema, inflammation, and large bile duct stones, which make access very difficult. Similarly, stones that are impacted in the bile duct or cystic duct would again constitute as a difficult bile duct stones. Unusual locations of bile duct stones, which can be intrahepatic, it can be sitting inside the cystic duct, they can actually be proximal to strictures, and barrel-shaped stones comprise of the difficult bile duct stones. For an endoscopist, patient who is old, the distal CBD arm is very short so that your balloon tends to slip by the stone, and it makes taking out the stone very difficult. Acute distal CBD angulation, making it a sigmoid bile duct and multiple stones, again constitute a difficult bile duct stone category. Coming to what is a large CBD stone. So as I mentioned, the literature is very varied. People talk of different cutoffs. Some studies say 1 centimeter, some studies say 1.5 centimeters. To an extent, some European articles have talked about 2 centimeters as a cutoff for large CBD stone as well. So this study was published in 2008 from SMS Medical College, where 304 patients who underwent sphincterotomy and CBD stone clearance realized that it was actually 16 patients who had difficult to remove stones. And these 16 patients were basically of two kinds. One, when the stone was genuinely large, more than 1 centimeter, making it difficult to come out of the bile duct. And the second was when the stone was actually small, maybe even less than 1 centimeter. However, the lower CBD diameter was less than 2 to 4 millimeter than that of a stone size. So they said that it's not the absolute size of the stone that makes the stone a difficult CBD stone. So any stone that is exceeding 2 millimeter, then the lower CBD diameter should actually be considered as a large CBD stone, is what they concluded. This is again, you can see a large periampullary diverticulum, and the papilla is actually hiding inside the diverticulum, making it slightly difficult to cannulate and subsequently deliver the stone. Then I was talking about the Mirizi syndrome, the stone impacted in the GB neck, which again would make taking out this stone very, very difficult. So what are the principles of treatment of a difficult CBD stone? First, you increase the CBD orifice from where you're actually delivering the stone. Point number two, you can decrease the stone size by using various modalities that I'll be talking about. And third, you try and dilate or negotiate the stricture or the stenosis beyond which the stone is actually sitting. So the treatment modalities for difficult CBD stones can be a medical treatment. There can be endoscopic treatment, that is what I'll be focusing about today, the percutaneous approaches, and the surgical treatment. So first is increasing the CBD diameter orifice. The papillary orifice from the stone is actually going to be delivered. I have talked about EST, that is endoscopic sphincterotomy, where one can see that the papilla has been cut thereby enabling delivery of the stone. Then we can talk about something called EPBD. EPBD stands for endoscopic papillary balloon dilatation or endoscopic papillary large balloon dilatation. What we use is a CRE balloon to dilate the orifice of distal CBD and the ampullary orifice, thereby taking out the stone much, much simpler. However, nowadays, EST is not used in isolation. EPBD is usually not used in isolation. It is combined with a sphincterotomy where you cut open a papilla slightly and then you use a CRE balloon to further dilate the tract, thereby enabling delivery of a stone more comfortably. So this is what I was talking about when I said EPLBD, that is endoscopic papillary large balloon dilatation. The question is, when do you use a papillary large balloon dilatation over a usual sphincterotomy to deliver a large stone? Patients who have coagulopathy, where you think cut would actually bleed, is where EPBD may be more suitable. Patients who have large stones and a large periampullary diverticulum, which have a high risk of perforation, if you're just using a sphincterotomy, EPBD may actually be more beneficial than a EST, that is a sphincterotomy. However, one must keep in mind that whenever you're dilating the tract, as can be seen in this image on the left-hand side, lower aspect, the bile duct diameter has to be commensurate with the diameter of the stone of the balloon that is being used. Otherwise, you can actually result in bile leak and bile perforation, which can happen if you're using a 10 millimeter or 12 millimeter or 15 millimeter CRE balloon to dilate the tract. This is one of the studies where complications of sphincterotomy alone or a balloon dilatation alone have been compared, and one can see the rates of bleeding as expected are higher in patients who are undergoing sphincterotomy alone. The rates of pancreatitis are higher in patients who are undergoing papillary balloon dilatation alone. The reason being that the papilla, the pancreatic sphincter, the pancreatic opening runs very close to the biliary opening. And when you're only using a balloon, it tends to get compressed and may result in higher rates of pancreatitis. So overall complication rates were comparable in both the groups. So EPBD is largely used where you want to preserve the papillary function. Patient has coagulopathy, patient has a large periampullary diverticulum, EPBD may be preferred over endoscopic sphincterotomy. Now coming to mechanical lithotripsy. Mechanical lithotripsy, again, I said your 80% stones would be delivered by usual modes. Another 10% patients who probably cannot be delivered, the stone cannot be delivered because of the large size of the stone or a narrower, lower CB diameter. What one can use, this is the Olympus Lithocrush mechanical lithotripter, where this is a metallic sheet. One can actually catch hold of a stone inside this metallic guide wire framework, and this metallic sheet goes forward, resulting in crushing of the stone inside the 4 wired chamber that one can actually see here. So it is used for endoscopic crushing of CBD stones where your sphincterotomy has failed, your usual techniques of pulling out a balloon or a basket clearance of CBD stone has failed. It is the most common technique used for difficult CBD stones, and stones that are usually more than 1.5 centimeters are very effectively crushed by mechanical lithotripters, obviating the need for surgical clearance. So this was again one study I quoted earlier from SMS Medical College. One can see that the rates of lithotripsy were not higher in those patients where the stone diameter was the maximum. Maybe a stone of even an 18 millimeter got delivered just by a basket without using a mechanical lithotripsy because the diameter of the bile duct was significantly more. However, if you see when the discordance between the bile duct diameter and the CBD stone diameter is significant, that is when the rates of mechanical lithotripsy were the highest. There are multiple factors that can affect the success of a mechanical lithotripsy. This was an again study from All India Institute of Medical Sciences, where they studied the predictors of unsuccessful mechanical lithotripsy, and they saw around 401 patients with CBD stones, and they realized that an impacted stone was the only parameter that was a predictor of failed mechanical lithotripsy vis-a-vis patients who underwent successful mechanical lithotripsy. So what are the types of mechanical lithotripters? There's a Sohindra mechanical lithotripter. I wouldn't dwell into details. It is used basically when a basket and a stone actually get stuck inside the bile duct, and you're using this as a salvage technique to take out the basket that is impacted in the bile duct by crushing it. And this is the Olympus V-Crush mechanical lithotripter that I talked about recently. So now talking about the role of biliary stenting. Is biliary stenting a first-line modality for large bile duct stones? No. When you are not able to take out a large stone, your stone is actually stuck in the bile duct, or patient is elderly and you're just wanting to buy some time patient is planned for surgery and you want to buy some time, biliary stenting can be helpful. Although there are studies which have shown that even CBD stenting with ursodeoxycholic acid in combination can result in stones becoming smaller, as one can see that after a few months of placing a biliary stent, number of stones, stone size and stone index actually went low. So CBD stent again can be used in very elderly patients that I talked about, and it can be used as a short-term therapy to salvage the crisis time, to salvage the cholangitis times, and then subsequently go in for a definitive therapy later. So now I have talked about endoscopic sphincterotomy. I have talked about large balloon dilatation of the papillary orifice. Mechanical lithotripsy also has been tried. Everything fails. What do you do next? So now what needs to be done next is you gain in the entry inside the bile duct. Till you see the stone, till you see the actual anatomy, you would not be able to deal with a large stone that is actually not coming out endoscopically. So now the question comes, how do you gain entry into a bile duct? Previously, per oral cholangioscopy was used. Even now, it is being used at some centers. Per oral cholangioscopy suggests that an ultra thin scope is actually progressed over a guide wire, and you can see in this cartoon that is depicted that this ultra thin scope can actually be advanced over a guide wire into the bile duct using a balloon catheter that helps in anchorage. The scope is actually advanced into the bile duct per se, and then the therapy that is warranted can actually be done. This is known as a per oral cholangioscopy. However, it is easier said than done. The reason being the scopes tend to keep looping inside the duodenum, and this balloon is not enough to give the kind of strength to facilitate the scope from entry into the bile duct and maintain its pressure there subsequently. Then there was a time when we talked about mother-daughter cholangioscopes, where you needed actually two gastroenterologists. One person is actually doing the scopy, holding the main ERCP scope, and the other person is holding a daughter scope. You can see that the daughter scope is actually introduced through the catheter channel of a ERCP scope. And there were times when mother-daughter system was actually used, but however, now they are largely redundant. The reason being the quality of image was very, very poor. The degree of freedom was only in one direction. And this has actually given way to what we nowadays call as a single operator cholangioscopy, and Spyglass DS2, the latest system, has actually been a game changer. So let me tell you how this Spyglass DS2 or a single operator cholangioscopy works using this video. This can actually get attached to your normal ERCP scope, this Spyglass DS version, and one can see that through a working channel, the catheter of a Spyglass DS system can actually be introduced inside a patient. You introduce a usual ERCP scope, just like you're doing a usual ERCP. You get to the papilla, and then using this cholangioscope, one can gain entry into the bile duct. Once your catheter is negotiated, one can do continuous irrigation to clean the debris, localize the site where the stone is actually there. So I initially did talk about stones that are stuck at the cystic duct neck, stones that are impacted. All of them can be visualized under direct vision, and subsequently using your laser probes or electrohydraulic lithotripsy probes, those stones can be broken down into smaller fragments and can be taken out using your basket or your extraction balloon using various means. This is how a Spyglass has actually been a game changer. Now I'm talking about lasers. How do lasers work? Laser probe can actually come out of a Spyglass scope that I showed earlier and can help in lysis of even difficult recalcitrant stones. So laser is light amplification by stimulated emission of radiation. A laser causes a sonic bubble, a sonic boom that causes a mechanical shock wave. And when you're actually working within 1 millimeter of the stone can actually get lysed by the sonic boom that is created by a vapor bubble. What one needs to understand is when you're trying to do a laser lithotripsy, the laser probe is supposed to come out of your working channel of a Spyglass cholangioscope, touch the stone, and then slightly pull it back so that it is within 1 millimeter of the diameter of the stone and it's not closely just abutting, because that is when the effect would actually be minimal. So this is again a direct peroral cholangioscopy. One can see inside the bile duct. This is a large stone that is actually there. A holmium laser has been used here to lyse the stone, and you can see the whole bile duct is actually clear of the stones. Talking about electrohydraulic lithotripsy, we must accept the fact that we are adopting a lot of technology from our urology colleagues. It was actually being used for bladder stones and subsequently adapted into biliary tree in 1975. So this is what an electrohydraulic lithotripsy generator looks like. This is a shock wave generator. This is the EHL probe that comes out through a cholangoscope that I showed in the cartoon that I showed earlier. And then you need access categories like a mother baby scope or an ultra thin endoscope or a spyglass direct visualization system that can actually enter the bile duct and create lysis of large stones. So this was actually a very interesting case we performed some time back. This patient had actually undergone an ERCP at our center 6 years back for a large difficult CVD stone. We failed to take out her stone, and subsequently we placed a biliary stent. This patient was actually lost to follow-up and subsequently presented 6 years later with a stent that had actually migrated inside the bile duct and the stone that was still present. So we decided to go ahead with a spyglass cholangoscopy and attempts to retrieve the stent and the stone. In this video, one can see I'm trying to introduce the spyglass DS2 version inside the papilla. One can see inside the bile duct that there's a large stone that is present. There is a stent that is present at around 11 o'clock position. And the stent stone complex is actually impacted, making removal of either very, very difficult. Under cholangoscopic guidance, a spy bite forceps, that is a bite forceps, is actually out. And I'm trying to hold the stent so that one can take out the stent. Now I'm holding the stent and slowly I will pull it out of the papillary orifice so that the stone can be disimpacted. One can see that the stent is out. Using a snare, the stent has been caught and subsequently removed. And then I enter the bile duct again using the cholangoscope and realize that the stone is still there and is still immobile. What one can see at 11 o'clock is an ulcer that has been caused due to the impacted stent that has been in situ for almost 6 years because the patient was lost to follow-up. And the stone is still there, which was still very difficult to take out because the longitudinal, big 2.5 centimeter stone that was actually sitting there. So now I have taken out the EHL probe, electrohydraulic lithotripsy probe, that is very close to the stone that is there in question. And I'm continuously irrigating. Irrigation is very, very important when you're doing a mechanical, when you're doing electrohydraulic lithotripsy. And what you can see is something that you see when you're driving on a road with heavy rain actually falling on your windscreen. So you can see that this stone is actually getting lysed. With continuous irrigation, the stone is being lysed into smaller fragments. And once the stone is actually being lysed into smaller fragments, we can use the usual ERCP mode that we use and take out these small stone fragments from the bile duct, enabling avoidance of a major surgery that probably would have been inevitable in a case like this. So there have been data of electrohydraulic lithotripsy, and the complication rates have been to the tune of 7 to 8%, and complete CBD clearance rates have been to the tune of 85 to 90% using electrohydraulic lithotripsy very, very effectively. So now when you compare electrohydraulic lithotripsy with laser lithotripsy, which one scores? We do not have a randomized controlled trial, and we do not have an answer which is better than the other. However, it has been seen that the single session stone clearance rate has been higher with laser lithotripsy. The stone fragmentation is better with laser lithotripsy. However, the equipment is way more costlier as compared to electrohydraulic lithotripsy probe. In my personal experience, both work equally well. So now talking about extracorporeal shockwave lithotripsy, here shockwaves are generating by an external piezoelectric crystal and the water spark gap underwater spark generator. And it has actually, again, been adopted from our urology colleagues, where it was used for urology stone clearance, especially the renal calculi. You have X-ray machine here, which helps localize the stone in the bile duct, especially the larger ones. And the shock waves that are generated are actually generated from this part of the screen. And on localization, the large stones can actually be lysed. One can see the shock wave lithotripsy can result in small fragmentation of bile duct stones, which can subsequently be removed. This was the largest study on shockwave lithotripsy from Asian Institute of Gastroenterology, and they showed that only ESWL along with the usual ERCP was successful in around 85% of patients. And studies from across the world have shown success rate varying from around 78% to 85% across multiple studies. The complication rates have been to the tune of 15%, including hemophilia, cholangitis, pancreatitis, and few purpuric spots that can happen. However, when we compare laser lithotripsy with ESWL, it has been shown that laser scores over ESWL in terms of stone clearance in single ERCP and fragmentation as well. So now talking about special situations, there are patients when ERCP cannot actually reach where you intended to reach using the usual ERCP scope. There's an altered anatomy, a Roux-en-Y limb is there. So what you would actually need is an enteroscope so that you can actually negotiate the whole of the Roux-en-Y afferent limb, go to the afferent limb, cannulate the bile duct, and then take out the stone using an enteroscope, which is known as enteroscopy assisted ERCP. Otherwise, percutaneous approaches by our radiology colleagues can also be helpful. Then our surgical colleagues can also come in handy under such situations, where what they would do is they'd provide you a nick at the small bowel and ask you to introduce your scope, because for you to actually take this afferent limb and go to the afferent limb and cannulate the bile duct is very difficult. They'd give you a nick and they'd ask you to progress your scope and do your ERCP and come out under laparoscopy assistance. Now, everything said and done, in the era of endoscopic ultrasound, what is very important to understand why EUS has become so important in nowadays era. In patients where you have altered anatomy, your stomach has been isolated and you have an afferent limb, what one can do is actually puncture the left lobe of the biliary radical and gain entry into the bile duct from the stomach. And thereby, you can see this is the cholangiogram that has been taken after gaining access into the left bile duct. And anterogradely, this is the papillary orifice that is being dilated by a balloon. And subsequently, anterogradely, the stone is being pushed out, causing with an extraction balloon. This is one of the patients where our usual ERCP cannulation failed and we could not gain access into the bile duct. What we decided to go ahead was with the US guided rendezvous procedure, what we actually do is we puncture the bile duct directly under US guidance, take out the guide wire through the ampulla, and using the guide wire from the ampulla, we gain access into the bile duct. So when we cannot go from the ampulla, from the duodenum, we gain access from anterogradely directly from the bile duct. So this is a small video depicting the same thing. This is the scope in a short position in the second part of duodenum. The anechoic structure that one can see is actually the bile duct. One can see few sludge-like material that is actually floating inside the bile duct. This is the 19 gauge US FNAC needle. One can actually see a stone as well inside the bile duct. Under direct echo endoscopic guidance, we take out the needle and we puncture the bile duct. Now I'm inside the bile duct in this case, and we are negotiating a guide wire across the ampulla so that once the guide wire comes out through the ampulla, we can use the same guide wire to gain access into the bile duct. You can see that the guide wire has actually coiled inside the duodenum, and using the same guide wire as an access, we gain access again back into the bile duct, making something that used to be very, very difficult initially, very simple. And this US guided rendezvous procedure can actually be completed in 10 minutes if the bile duct is well visualized. Now, talking about surgical approaches, there can be a laparoscopic CBD exploration or an open common bile duct exploration, which our surgery colleagues are well adept with when we fail, and they're always on our back when endoscopic techniques are actually not very successful. Coming to conclusion, difficult CBD stones comprise of a group of conditions which are associated with difficult bile duct stones, unusually large stones, impacted stones, stones that are located at unusual locations. However, around 80% of CBD stones can be taken out with routine sphincterotomy, balloon dilatation, and extraction balloon or baskets. However, another 10% can be extracted with the help of mechanical lithotripsy. Modalities to gain access inside the bile duct, that is spyglass system or a single operator cholangioscopy, has been a game changer. Now we have electrohydraulic lithotripsies, we have laser lithotripsies, we have ESWLs, which are modalities to break difficult stones and inaccessible stones that used to be outside an endoscopic domain at some point of time. Double balloon enteroscopy, laparoscopic assisted ERCP have a role when you have altered surgical anatomy, and US is definitely coming up in a big way in treating these difficult stones. Thank you.
Thank you very much, Dr. Gaurav, for an excellent lecture on how to deal with difficult CBD stones. And questions will be taken at the end of fourth lecture. Thank you very much once again.
Thank you, sir.
Now we go on to the third lecture, which will be delivered by my colleague, Dr. Alok Sehgal, who is director at the Premier Gastroenterology Institute, Jalandhar. He will be talking on non-obstructive dysphagia. Dr. Alok Sehgal, please.
Good evening. I am audible to House?
Yes, sir. Yes, sir, you are.
Okay. So,
Can we share the screen as well, sir?
yeah, I'm trying. Just a second.
Okay.
So, still, can you see my screen?
No, sir. No, sir.
Still not. Okay, just a minute. Is it okay now?
Yes, yes, sir.
Okay.
Perfect.
So let me go into now. Is it okay now?
Yes.
Yes, sir. Yes, sir.
So good evening, everyone. Very two wonderful lectures by Dr. Gaurav and Dr. Siddharth, and they have talked nicely about the interventions in gastroenterology. One of the pancreatic disease and CBD stone, both are both challenging diseases. And my job is very simple and very basic topic, which we deal in our daily routine clinical practice, dysphagia. And I am going to discuss only a small part of dysphagia, that is non-obstructive dysphagia. So we all know the dysphagia, that is derived from a word, Greek word, difficulty in swallowing, difficulty eating. So any patient who comes with dysphagia, they have symptoms, variety of presentation of symptoms. And we all know it is a very worrisome symptom, because sometimes the cause can be such that can be very detrimental in her or her life. And these symptoms are why worrisome? Because if conditions like malignancy are there, then they need to be urgently treated. And all these patients with dysphagia needs urgent attention and adequate treatment accordingly. So coming to the definitions. So any subjective sensation of difficulty or abnormality of swallowing in absence of mechanical cause, we label them in the cause of non-obstructive dysphagia. Again, this is a wide group. Other similar definitions in patient with the dysphagia are who they complain of subjective sensation are global sensation, that is sensation of foreign body or retained food bolus in throat. The characteristics about this is relieved swallowing. Other is the painful swelling is called adenophagia. And sometime in elderly age group, around 16% of the elderly population, they may complain of xerostomia. Due to xerostomia, they may complain a sensation of difficulty in swallowing of food. So before I go ahead, we should follow, we have to understand the normal swallowing. The normal swallowing is a very interesting and very coordinated process. And we know there are three phases of swallowing. There's an oral phase, then pharyngeal phase, and then another is the esophageal phase. And all these phases are so well coordinated, and these all occur on precise and coordinated member. And almost a normal person can swallow at least 600 times a day, and without knowing it, our swallowing process goes like this. There are more than 30 group of muscles which are involved in the normal swallowing. So how the swallowing starts, I will start with the one cartoon. And we all know this is a buccal phase or oral phase. As we take the swallow, the bolus is chewed and masticated with the help of saliva to appropriate size, shape, and consistency, so that it can be pushed across the hard palate into the soft palate with the help of the movement of the tongue. As the bolus moves into the hard palate to these comes the oropharynx, then there are various group of muscle, especially the levator and tensor villi palatini. They comes in action along with the pharyngeal muscles, and the signals. There are various receptors in the pharynx which send signals to the medullary center, medulla oblongata, and lower pons, where there is a brainstem, whereas the swelling center is there. That helps in the closure of the uvula, soft palate, and complete closure of the nasopharynx, so that to prevent the nasal aspiration while swallowing. Other signals reaches the epiglottis, which inverts and cover the laryngeal vestibule to prevent the aspiration. And relaxation of the upper esophageal sphincter also occur, and the food bolus is pushed across the pharynx into the esophagus. And again, in the esophagus, there is a well-coordinated movement of the longitudinal and circular muscles, which help in the peristalsis and guiding the bolus from the esophagus into the stomach. And characteristic around the swelling is that initiation of swallowing and transfer of the food bolus from the oral cavity to esophagus takes less than 1 second. A very interesting thing. And rest of the swelling is around 10 to 50 seconds, means transfer of the food bolus from the upper esophageal sphincter till esophagus. It takes around 10 to 15 seconds. So the movement of less than 1 second, it involves more than 30 muscles and is very precise and well coordinated. So anywhere in the process of neuromuscular control is damaged, that will result in the dysphagia. Similarly, a picture from our textbook of gastroenterology. So there is a fluoroscopic and high resolution manometry. We can see the bolus in the mouth, the upper esophageal sphincter is contracted. As the bolus moves, then there is a relaxation of the upper esophageal sphincters along with the movement of the levator muscles of the soft palate, so that will prevent the blockage of the nasopharyngeal area that we see in the cartoon. And subsequently, there are various things. As we start swallowing, the various glossopalatal junction, velopharyngeal junction closure, vestibule laryngeal closure, and UES upper esophageal sphincter opening occur in a less than 0.1 second or 1 second. And subsequently, as the bolus is passed across the pharynx into the esophagus, again the UES goes back to the contracted state. And in the esophagus, there are also 4 phases. First is the accommodation phase, as the bolus enter into the esophagus. And the second is the compartmentalization, in which as the bolus enter into the esophagus to the esophageal body, till that esophageal junction is closed. As the bolus peristalsis starts in the stage 3, that is known as the esophageal emptying phase, then esophageal junction become open, and subsequently in the last stage, as the bolus reaches the distal esophagus, the ampullary emptying occur, which is slightly distinct from the normal peristaltic movement, and followed by the closure of the lower esophageal sphincter. So anywhere in the process of initiation of the oropharyngeal to esophageal, any abnormality can result in the dysphagia. Now, if a patient comes to the ROPD with dysphagia, how we go ahead with that? So once we take the history is very important, and examination too. And if we ask the patient, is there any difficulty initiating swallow, or swelling occurring almost within seconds, or not within seconds, exactly in 1 second of the swallow, we label it as oropharyngeal dysphagia. And if the food stops or stick after swallowing, we usually label it as esophageal dysphagia. So these are the mostly question we ask in our practice that during dysphagia. So do you have problem in initiating a swallow, or do you feel food getting stuck, or is there a symptom like cough, choking, or food coming back through the nose while swallowing? Any problem regarding especially to solid liquids or both? And how long you have been problem swelling, and whether symptom has progressed, remained stable, or they are intermittent. So other few important things, any associated other symptom, loss of appetite, weight loss, or any other associated systemic diseases, diabetes, scleroderma, Sjogren's syndrome, AIDS, neuromuscular disorders, muscular dystrophy, myasthenia, or recent any history of chemotherapy, or any history of radiation or surgery, or any other medication. So these are the 4 questions if we ask in our patient with dysphagia. Any of this can suggestive of oropharyngeal dysphagia. Most important is there any delay in initiating the swallow? Other is there a deglutive postnasal regurgitation? Is there any deglutive cough? And another one is repetitive swallowing needed to achieve satisfactory clearance, meaning repeatedly pharyngeal clearance to push the bolus from the pharynx into the, a repeated swelling, a movement of the tongue to push the swelling food from the oropharynx into the pharynx. So any of the question answered to yes may suggestive of oropharyngeal dysphagia. And the important symptom of oropharyngeal dysphagia are food spillage, drooling, nasal regurgitation, coughing, choking, regurgitation, and indirect symptom like repeated chest infection, aspiration, prolonged meal duration, weight loss, and change in voice articulation. And the important causes, as discussed earlier also. So these are the mechanical events and of oropharyngeal swallow, evidence of dysfunction and disease association of patient with the oropharyngeal dysphagia. If any problem with the nasopharyngeal closure, the patient will complain of nasopharyngeal regurgitation, nasal voice, just like example of myasthenia gravis. Other thing, if the patient has problem with the laryngeal closure, if the epiglottis does not cover the larynx vestibule, the patient may aspirate during bolus transit. So most like such cases are seen in traumatic brain injury or stroke. If the patient have tight upper esophageal sphincter opening, that also result in the dysphagia and may also result in the diverticular formation and may also result in post-swallow residue or respiration as the food will not be emptied from the pharynx into the esophagus. The residuous food may get aspirated, especially in patient with the Parkinson disease. Similarly, if the problem is like Parkinson disease or surgical defect or cerebral palsies, these patients also have problem like tongue loading and bolus propulsion. And if there is again stroke or any oculopharyngeal dystrophy or polio, these patients may also have problem in pharyngeal clearance, so that pharynx is not adequately cleared and patient may develop a post-swallow residue in hypopharynx or may result in aspiration. For the evaluation of the oropharyngeal disease, the most important of this, you can say one of the best investigation is the video fluoroscopy. So video fluoroscopy is the dynamic continuous radiological examination of oral cavity, pharynx and upper esophageal sphincter, and that includes lateral and frontal x-rays. This is done in a specialized seated chair with the help of fluoroscopic x-rays. And this picture we can show one of the picture taken from the book, showing the cricoexangular bar. So the important thing is the clearance about the anatomy and the presence of radiologist, and in which the video fluoroscopy is done, and regularly each and part examined how the patient does the swallowing movement. Endoscopically, such patient can also be evaluated with the help of nasal endoscope. The nasal endoscopes, they are portable, easy to carry, and the patient usually tolerate this procedure, and we can see the mucosal surface and movement of tongue base, larynx or pharynx as the bolus moves, and also we can see the movement of the epiglottis, how it covers the vestibule. And for the management of the patient with the oropharyngeal dysphagia, we have to find out the cause, if the stroke is there or any muscular dystrophy is there, and if the illness is going to be long lasting, we have to think of the other way of feedings, non-oral feedings. We have to think of gastrostomy or other things. And if the patient have any condition which can be managed surgically, or like Zenker's or cricopharyngeal bar, then we can consider of thinking of myotomy. And if the patient is suffering from the reversible condition, which can be potentially amenable to therapy like dietary modification, swallow therapy, and we can we should take the help of the other colleagues, and we should consider on those time temporary non-oral feeding time. So coming from the oropharyngeal dysphagia to the esophageal dysphagia. Esophageal dysphagia, we all know that it can be solid related, as we see in the most of the practice, if the cause is mechanical, whether it is progressive or intermittent, depending upon the cause, like stricture, if it is a not associated weight loss. If it is associated with significant weight loss, then etiology like malignancy should be kept. And if there is intermittent symptoms like web ring or eosinophilic esophagitis is a very important cause. And if the patient mainly complains of dysphagia to liquids mainly and solid subsequently, one should considering a motor cause, again, which can be progressive or intermittent. The progressive cause, which is best described, are like the ecclesiocardia, scleroderma, and other mentioned in the books is the Chagas disease. And intermittent other causes are the other motility disorder, especially like distal esophageal spasm. Eosinophilic esophagitis can also behave as a motor cause, because most of the time, some of time we can also get a normal endoscopy. So Chicago 4 classification, they have divided the motility disorder in two groups. One is the disorders of the esophagogastric junction outflow obstruction, and others are the disorder of the peristalsis. So type 1 to type 3 ecclesia, along with the esophageal junction outflow obstruction, they are included in the disorder of EGJ outflow obstruction, and the disorder of peristalsis, which can be absent contractility or distal esophageal spasm, hypercontractile esophagus, or ineffective esophageal motility. So these all can be diagnosed and will be discussed further in the manometry. So esophageal motor disorders. We all know the anatomy of the esophagus. Esophagus has upper 1/3 as a striated muscle, which behaves similar to the oropharyngeal dysphagia because it is just like a transfer dysphagia. As in oropharynx, mainly motor control is affected because of the neuromuscular diseases or stroke. Similarly, in CVA, myasthenia, and Parkinson, the upper esophageal, which is of striated muscle, can be affected similar way as in oropharynx. And smooth muscle disorders, as mentioned, ecclesia, outflow obstruction, spasm, and scleroderma are there. So how to diagnose a non-obstructive dysphagia, especially the esophageal one? So there are three modalities with us at presently: upper GI endoscopy, barium studies, and high resolution manometry. So endoscopy can be normal in a patient with the dysmotility. So what are the no as such characteristic we can found on endoscopy with the patient with the dysmotility, but there are some features like we can see like dilated lumen, presence of liquid residue, and resistance while negotiating the LES. So if there is significant resistance is present at LES, one should think in the mind that it could be other than the dysmotility disorder. Very dilated lumen, presence of sometime candidiasis, even sometime food residue present in the lumen, and sometime there is an ulceration of the mucosa because of the persistent residual food content in the dilated esophagus. So these are the subtle features on the endoscopy which can pick in a patient with the dysmotility syndrome. So again, a comment on esophageal esophagitis. Dysphagia can occur in patient. Around 15% of the patient, they may present only as dysphagia in eosinophilic esophagitis, and they have normal endoscopy. So dictum should be any patient with the normal endoscopy, this should be scoped, should be taken endoscopic biopsy to rule out eosinophilic esophagitis. And characteristic is presence of more than 15 eosinophil per high field feet is a very characteristic of eosinophilic esophagitis. These patients, if normal endoscopy, we do high resolution manometry also, they can also have picture like ecclesia cardia or esophageal spasm. In one of the studies, around 21 patients with the eosinophilic esophagitis, around 48% of the patients have pan-esophageal pasteurization, which is similar as in we found in ecclesia cardia. And around 28% patient had other peristaltic defect like diffuse esophageal spasm. So this is a very important possibility in any patient with normal endoscopy with dysphagia. Other characteristic which we mentioned in the books are feline rings, trachealization, soft exudates, and linear furring of the lumen. So other investigation is barium swallow. It has a sportive role in diagnosis. Earlier, prior to the era of endoscopy and manometry, initially, they carry a lot of importance. Presence of dilated esophagus and bird beak like narrowing at the lower end, they are highly suggestive of ecclesia cardia. And if there is a focal contraction or there is a corkscrew-like appearance of the esophagus, they are typical of distal esophageal spasm. Other important investigation in the barium is the time barium esophagogram. This is basically developed to find the patient response to therapy, especially in the ecclesia cardia, but still can be also as a diagnostic purpose also. In this, left posterior oblique films are taken at 1, 2, and 5 minute interval, and basically to assess the quantitative assessment of degree of esophageal emptying on barium swallow. The around 150 ml of barium swallow is given to the patient, and followed by the barium esophagogram is done at a respected time, in which we take the width and the height of the barium column, and subsequently we assume that in a normal person, around 80% of the barium pass through the G junction, and almost all patients at 5 minutes they clear out their barium. But in patient with the dysmotility, they may have hold up of the contrast across the G junction, and we can measure the from the length of the column at 5 minutes, what is the height of that column. And subsequently, if we subject the patient to the therapy, for example, as shown in this picture, the ecclesia cardia followed by there is a pneumatic dilatation, and followed by there is a passage of the balloon, there's easy passage of the contrast and almost clearance of contrast at 5 minutes. If there is a poor response to the treatments for like pneumatic dilatation, still the patient in this picture have again significant barium column. To label it as a response to treatment, at least 50% decrease in height should be there. So coming to the other investigation, high resolution manometry. We all know This is the gold standard for the diagnosis of the esophageal motility disorders. And there are two machines, water perfusion and solid state. And so water perfusion a machine, this is a catheter which is placed across the through nose into the G junction, into the stomach, and various interluminal pressure and the various coordinated movements of the esophageal muscles is recorded. And from this picture, you can see it provides a nice diagrammatic presentation of a normal peristalsis, in which we can identify the upper esophagus sphincter, if you can see my cursor. And then there is a peristalsis. And can you see my this cursor, please? And this is the peristalsis, which is across, moving across the esophageal length. And this is the lower esophageal sphincter. As the upper esophageal sphincter relaxes, opens, the LES start relaxing. As the bolus starts transfers into the esophagus, the LES become relaxed. And in this esophageal manometry, there are a few things we have to think: upper esophageal relaxation, then esophageal peristalsis, relaxation of the LES, and we can diagnose the patient with the esophageal motility disorder. So there are important conditions. We can see ecclesia cardia, and manometrically ecclesia cardia has been defined three sets. And the important thing regarding the diagnosis of the ecclesia cardia is you can compare each picture with the manometric finding of the ecclesia with the normal peristalsis. So in ecclesia, there are two things: absence of esophageal peristalsis, and most important is the high LES pressure. This is high integrated relaxation pressure. And one can see the absence of peristalsis and high IRP is suggestive of ecclesia. And if it is manometrically categorized into three categories: type 1, type 2, and type 3. And in type 3, we can there are associated esophageal spasm are there. And type 2, there is pan-esophageal pressurization in almost more than 2 swallows. Similarly, other condition is the esophageal junction outflow obstruction, which can also be manometrically diagnosed. In this, the patient has normal peristalsis, but there is a defect in the outflow obstruction, that the patient has very high RP. This is the difference from the ecclesia cardia. There is absence of peristalsis. In EJJ outflow obstruction, there is a peristalsis, but there is a IRP is very high. So other are the absent contractility. In this, we can see there is a relaxation of the UES, but there is no peristalsis, and LES is also relaxed. This kind of picture, manometric picture, we get in conditions like scleroderma, which affect the smooth muscles, which affect both the esophageal muscles, smooth muscles, and the lower esophageal sphincter, which result in the relaxed LES and absent of peristalsis. Sometimes such conditions can be missed. Ecclesia can be missed because if the esophagus is markedly dilated, sometimes we get absent contractility along with the low LES pressure. So ecclesia have to be ruled out. And at this kind of scenarios, we have to take the help of the sportive evidence from the help of barium swallows or other modality, which will be discussed later. Another manometric is the ineffective esophageal swallow. That means the strength of peristaltic contour is very low. We take DCI as a minimum of 450. If it is less than that, it is called as 70. It is less than 450, we labeled as ineffective. And if it is less than 100, then it is fail. There is a transition zone between the striated muscle and the smooth muscle. If this zone is more than 5 centimeter, we label it as a fragmented esophageal swallow. And for the hypercontractile conditions like esophageal spasm, and we again there is a peristalsis, and in this characteristic is there's esophageal spasm, and the distance between the swallow and this is less than 4.5, again, which is characteristic of DES. So I'm not going into detail of Chicago 4. So this is in a new classification, just have upgraded from version 3. and they have given the flow chart regarding the ecclesial manometrically diagnosis of the ecclesia, and they have spotted the if there is unequivocal response on manometry, one has to take the help of barium swallow or condition like of help of barium swallow, and the other investigations like functional luminal imaging probe. This is end of lip. So these are available on the Research Institute, where the and in this the data for last few years they have shown that it provides two things. This is the catheter, which is mounted with the electrodes and with balloon inflated mounted at lower end, placed transorally with the help of endoscope across the GE junction, and it provides the distensibility of the esophageal lumen. And other thing, it measures the esophageal wall stiffness and dynamics of esophagogastric junction. It can also provide the 3D image of the pressure changes across the esophagus, diameter and volume. And along with the help of manometry, barium swallow, and end of lip, one can diagnose accurately the various luminal esophageal motility disorders. One thing has to be kept in the mind, a condition like pseudoecclesia, because any patient, if present, elderly patient presenting age more than 50 with Abraham Thompson of symptom of less than 1 year and significant weight loss, they should be think about pseudoecclesia rather than condition like ecclesia or esophageal motility disorder, because we will get a significant resistance at G junction. In such scenario, one has to be careful, look the distal esophagus and fundus, and one should take the help of imagings like CECT or MRI and endoscopic ultrasound to evaluate the lower end. So as per other condition is a functional dysphagia. So functional dysphagia.
We're running a bit late, Dr.
Yeah.
Look, can you hurry up?
I'm just winding, Dr. One. So according to the Rome 4 criteria, if the patients have everything, endoscopy is normal, manometry is normal, barium swallow is normal, and there is no esophageal and absence of any major motor disorder, the condition is known as functional dysphagia has been kept. And for criteria, it has been laid down for this dysphagia in presence of all normal investigations for past 3 months, for at least 6 months, they should be labeled as functional dysphagia. And this group of the patient, as per Rome criteria, they advocates the Bucci dilatation of the esophagus, which was published study around in 1996, and further American Association of Gastroenterology did not recommend this kind of dilatation, but still Rome 4 criteria still for such group of patient, they advise esophageal Bucci dilatation. So summing up that management of the, I'm not missing, skipping this slide. So summing up the assessment of dysphagia, one has to clearly differentiate oropharyngeal dysphagia and esophageal dysphagia. And for oropharyngeal dysphagia, video fluoroscopy and nasal endoscopy should be done. And for esophageal dysphagia, one has to think endoscopy plus minus need of biopsy to rule out eosinophilic esophagitis. If it is normal, then should be subjected to the high resolution manometry and barium swallow if needed, and treated accordingly. So thanks for patient hearing.
Thank you very much, Dr. Alok, for this very educative lecture on non-obstructive dysphagias. So we will be taking questions, answers later on. And now we move on to the fourth lecture, which will be delivered by Dr. Shalimar, who is additional professor in Department of Gastroenterology at AIIMS, New Delhi. The topic is management of hepatic encephalopathy. Professor Shalimar, please.
Thank you, sir.
Before Dr. Shalimar starts, I would request all the delegates to post their questions, because next we will be taking up all the questions. So there is a ask question button in front, on your screen. So you can type your question there, and we will be all our speakers will love to answer all the queries regarding these topics. Thank you. Thank you, Dr. Shalimar. Sorry for interruption. Please carry on.
Not an issue. Thank you, Dr. Amit, and thank you, Nanda sir, for this kind invitation to talk on hepatic encephalopathy management. So in the next 15 minutes or so, I'll talk on the following subheadings. I'll give few clinical presentations of patients with hepatic encephalopathy as case scenarios. I'll talk to you about pathogenesis and the management options which we have and the outcomes of these patients with the different therapies which we have. So our case one for today is Mr. BW, who's 48 years old male. He is consuming alcohol in serogenic doses and has been diagnosed cirrhosis for past few years. He comes to you in the emergency as these patients will have a first presentation with altered sensorium. So that's the topic what we are going to discuss. So he's presented to you in emergency. Now from here, how do you approach such a patient? So hepatic encephalopathy is broadly defined as brain dysfunction, which occurs in a patient with liver insufficiency and or photosystemic shunting, which manifest with a wide spectrum of neurological or psychiatric abnormalities. So when you're evaluating such patients in emergency as first presentation, the clinical presentation may be very bizarre. So it's very important to know the background, that is, what the patient's underlying disease is. So if he's a known case of chronic liver disease, then possibility of making a diagnosis of hepatic encephalopathy in this patient is high. But you also need to keep in mind there is a myriad of differentials which you need to keep in mind while evaluating such patients. And not every patient with hepatic or who presents with such kind of presentation will have hepatic encephalopathy. So patients with cirrhosis can also develop other possible causes or other differentials. So you should always keep such differentials in mind. Broadly, hepatic encephalopathy can be categorized into different classes, A, B, C, depending upon acute liver failure, underlying photosystemic shunting, or underlying chronic liver disease. It may also be graded depending upon the severity of the grade of hepatic encephalopathy and classically labeled as minimal hepatic encephalopathy, grade 1 to 4 hepatic encephalopathy. Recently, ISHN has categorized these patients, that is, with minimal and grade 1 as covert, 2 to 4 as overt. Apart from this, it can also be categorized as episodic, recurrent, or persistent, or spontaneous, or precipitate. So let's coming back to our patient. He's presented to you in emergency, you're evaluating it. So the approach remains, one is the general measures. You need to always maintain in a patient who's sick as airway, breathing, and circulation. That forms an important basis of management of any sick patient. Next is rule out all possible causes of altered sensorium in this patient. So as discussed, patient may be a first presentation or patient may be a known case of chronic liver disease. We know now that chronic liver disease, most common etiology is active alcoholism. Patient who's consumed, who's an alcoholic binge may also present to you with an abnormal behavior. These patients may have had head injury, and unless we have a definitive evidence, we cannot always rule it out. Drug overdoses are also common. Patient may be abusing drugs or must have taken or may have taken other drugs prescribed, sedatives. Also, take a history of fever. GI bleed is another important precipitant which may cause altered sensorium in these patients. In addition, do always ask history of constipation and dehydration. So what we are doing out here is identifying precipitants which may be the reason why the altered sensorium episode has been seen in this patient for the first time. Once you have done this, from the history, you move to investigations. Look at the electrolytes. They are very commonly hyponatremia, can occur in patients with chronic liver disease because of diuretics. Look at the kidney function test, uremia, thyroid profile as required. An arterial blood gas analysis may be required in certain cases. Ammonia level estimation is important. If you have facility, do always assess for the ammonia levels. A normal level rules out. An elevated level of ammonia may be because of multiple factors. Always rule out infection in these patients because infection per se could be an acute precipitant and also may lead to worsening of hepatic encephalopathy grades in these patients. Most importantly, do not forget we are endemic for malaria, dengue, and also meningitis can have a similar presentation. So you need to rule out each of these as per the clinical scenario which the patient presents. Now coming to specific measures. Specific measures, the drugs are targeted at two mechanisms of action. One is ammonia reduction, second is intestinal microbiota modulation. Important general measures which you also need to keep in mind when a patient has an advanced hepatic encephalopathy, that is grade 3 and 4, or his GCS is poor, consider for intubation because this will help you in preventing aspiration and will help in improving the outcome of these patients. In addition, when you're looking, important question comes in, do you subject the patient to a CT head? So a CT head should be considered when a patient has come to you for a first presentation of hepatic encephalopathy. And if there is a history of seizure, there is a history of headache, a documented fall, or if you find on examination there is a focal neurological deficit, do always ask for a CT head. And if a patient comes to you with recurrent episodes, depending upon the clinical scenario, you can take an individual call whether to subject this patient to a CT. Usually it would be a non-contrast CT to rule out the bleed or the trauma which has occurred. So now our patient's follow-up was, we did his electrolytes, blood sugar, KFT were all within normal limits. Sepsis screen was negative, procal was negative, counts were normal. He had grade 2 hepatic encephalopathy. Ammonia levels measured were 98 micromoles per liter. Non-contrast CT head didn't reveal any abnormality. So what is the next step? Now coming to the next step is specific management of hepatic encephalopathy overt episode. So before I talk about that, pathogenesis of hepatic encephalopathy is multifactorial. There are multiple factors: ammonia, inflammation, oxidative stress, bile acids, lactate, all play a role. There is a increased blood-brain barrier permeability, increase in levels of glutamate, neurotoxins, which leads to brain edema. In addition, there is a change in glutamine levels, which all lead to astrocyte swelling. So your brain gets swelled, though the rapidity of events occur more commonly in patients with acute liver failure as compared to those with chronic liver disease and hepatic encephalopathy related to that. In addition, there is an increase in GABA, and that all complex interplay leads to a clinical manifestation of hepatic encephalopathy. So, to reiterate again, we're looking at multiple factors, etiologies like alcohol, sepsis, complications, hyponatremia, other complications like GI bleed, renal failure, all leading to complex interplay, hyperammonemia, other factors which play, that is diabetes, increased GABA, small intestinal bacterial overgrowth, and bacterial translocation. Hence, all this complex interplay of pathogenesis leads to a clinical presentation. So, ammonia produced predominantly by kidneys and gut, metabolized by liver. The liver is not working in chronic liver disease, leads to a surge of ammonia levels. Ammonia levels are more higher in patients with acute liver failure as compared to ammonia levels in those with chronic liver disease and associated hepatic encephalopathy. So this increase in ammonia level leads to this complex interplay of changes in the brain, which manifests as hepatic encephalopathy. Now coming to the important management aspects. So we have our patient who's got an acute overt grade 2 hepatic encephalopathy. We've ruled out all possible precipitants. So we are now modulating the ammonia levels and the gut microbiome. So the drugs which have been shown to be effective includes lactulose, given at a dose of 30 ml, 3 to 4 times. Our aim out here in this patient is to have 2 to 3 loose stools per day. Route of administration preferred is oral. As the patient is in altered sensorium, we cannot give him oral feeds. So a Ryle's tube can be put, a nasogastric tube, and if nasogastric tube is not possible, then enema can be used in almost like 2 to 3 times a day. And we continue these above doses till the time there is clinical improvement. There would be a subset of patients who get side effects, who do not tolerate lactulose. In that subset of patients, we can start him on rifaximin And once it's started, it is continued indefinitely. There are other drugs like L-ornithine aspartate and polyethylene glycol. So, do we give a combination of lactulose alone, or or say rifaximin, or a combination of lactulose plus rifaximin? So, data would suggest that if a combination of these two drugs is given, that the recovery of hepatic encephalopathy and the overall survival in patients receiving combination is better than the individual drug. So, start both drugs in combination. L-ornithine L-aspartate has been shown to be effective in improving the recovery in patients with overt hepatic encephalopathy in cirrhotics. It reduces the ammonia levels and hence improves the and leads to an early recovery of an episode of hepatic encephalopathy. Meta-analyses have shown that patients with hepatic encephalopathy and those with overt hepatic encephalopathy. So that means all trials, including all patients with hepatic encephalopathy and those with overt, there is definitely a benefit of use of L-ornithine L-aspartate. In addition, LOLA has also been shown to be effective, whether given as an oral or an IV preparation in patients with minimal hepatic encephalopathy also. So if a patient is not responding, or what are the other options do we have? This interesting trial compared lactulose versus PEGLEC, that is polyethylene glycol, for treatment of an acute attack of overt hepatic encephalopathy. What they showed is use of PEGLEC was better as compared to lactulose. So we've got multiple drugs in our armamentarium to manage such patients. Problems with these drugs: lactulose has issues with taste, it causes GI symptoms, bloating. Issues with rifaximin, there is a risk of resistance, though it is not absorbed. PEG, that is PEGLEC, may cause use of 4 liters, is going to cause you of lots of fluid and electrolyte imbalances in patients with cirrhosis. There are other drugs also like neomycin, which causes ototoxicity, and metronidazole, which causes neurotoxicity, hence are not preferred in the management of hepatic encephalopathy. So the follow-up case, he was started on a combination of lactulose and rifaximin, he recovered, and he was planned for discharge. So what advice are you going to give when he is discharged? Importantly, when patients who recover from an episode of hepatic encephalopathy, even when they are treated with lactulose, they have got high risk of recurrence of these symptoms of hepatic encephalopathy. 2 studies showing almost like 40% and 42% recurrence at 1 year. So these patients are going to go back to hepatic encephalopathy. So what would be our advice? So very importantly, when you discharge such patients, give them secondary prophylaxis. Secondary prophylaxis drugs include similar to what we use in treatment of acute overt hepatic encephalopathy. So this study showed that use of lactulose as compared to placebo was associated with lower risk of hepatic encephalopathy during follow-ups. An interesting study on rifaximin, though, actually was a combination of rifaximin plus lactulose versus lactulose alone. What this showed is use of combination prevented development of recurrent encephalopathy in these patients. That is, those patients who had one episode of encephalopathy, if you treat them with a combination, their chances of getting another attack of hepatic encephalopathy reduces with a combination of rifaximin and lactulose. Similarly, this combination was associated with less hospitalization. There are other drugs like probiotics, which have also been shown to be associated with reduction. Problems that these are only with small sample size studies and we need more data. So the available data is predominantly on lactulose and rifaximin for secondary prophylaxis. So what are the other drug options for management of secondary prophylaxis for hepatic encephalopathy? So the drugs which we talked about are acting on ammonia metabolism. We've got drugs like L-ornithine L-aspartate, L-ornithine phenyl Essentially, what both of these are doing is removing ammonia from the body. In addition, there are multiple drugs like branched chain amino acids, glycerol phenylbutyrate, sodium benzoate. Each of these can be used in individual situations where you feel that patient is not responding, you want to add on, but presently the available data doesn't support the routine use of these agents for management of hepatic encephalopathy as secondary prophylaxis, but they can be used on individual basis. In addition, a recent data suggests probably an upcoming role of fecal microbiome transplantation. As the available data is very scant, this cannot be recommended for routine use. But yes, for clinical trials, this is one area which we look forward and could be a game changer in the management of hepatic encephalopathy. Drugs like zinc and L-carnitine have also been shown in small sample size studies to be effective. So coming to our second case, so this is Mr. BW again, who is a known case of cirrhosis, alcohol related. He seeks an opinion in your OPD for excessive sleepiness and has been diagnosed as minimal hepatic encephalopathy. He's had never had an episode of overt encephalopathy, and when you examine him, he has a little bit of flaps, and then he says, I feel sleepy during the day. So aim out here is to improve his quality because his quality of life is affected by this, and is to prevent another attack of overt hepatic encephalopathy. So in a nutshell, this is an interesting in-network meta-analysis which shows that drugs like rifaximin and lactulose have been shown to be effective in preventing or say reversal of minimal hepatic encephalopathy in your patient. So you can use either rifaximin or lactulose in such patients and improve their quality of life. And in order to prevent progression to an overt hepatic encephalopathy, similarly, drugs like lactulose and LOLA have shown to be effective. And other drugs, though, have been shown to be effective, but the quality of evidence available till date is much, much lower. So the standard drugs could be lactulose and L-ornithine, L-aspartate, which again act by reducing ammonia levels. Ammonia is controversial, lot of debate. What we showed is ammonia definitely can help you categorize your patients depending upon you can predict the outcome in a sick group of patients where higher levels of ammonia are associated with poor outcomes. And those patients with advanced encephalopathy have a poor outcome. So therefore you need to target and manage such patients in order to improve the outcomes. A word about Mars. Mars came with a big bang, but unfortunately didn't work. It didn't improve the outcomes, but what this study showed that possible it may have some improvement in hepatic encephalopathy. So we're looking at more artificial liver support devices in the future, which could be beneficial in the management. Plasma exchange is another upcoming modality for management. It helps in improving encephalopathy. It needs to be seen how we can use this modality in management of patients with cirrhosis. CRRT has been shown to be of benefit in patients with acute liver failure. Its role in management of hepatic encephalopathy and chronic liver disease still needs to be clear with time, and we need more studies on that. A word about liver transplantation. Hepatic encephalopathy advanced, that is grade 3 and 4, is defined as an organ failure, that is brain organ failure as per the EASL ASLD definition for ACLF. And definitely if your patient has an indication for transplant, he needs to be considered for transplant. And yes, for recurrent and refractory HE, on a case-to-case basis, you need to take a call for considering your patient for liver transplant. Now, coming to my final case before I end, is Mr. X, whose 40-year-old male has presented with recurrent episodes of altered sensorium. He doesn't have ascites. He's perfectly stable. You do his complete evaluation, you find that he fits into something like a child A, and all his workup is negative. And his CT scan shows a large photosystemic shunt. So data suggests that blocking of these large photosystemic shunts is associated with improvement in grades of encephalopathy. It reduces the number of hospitalization, and overall fraction of patients with hepatic encephalopathy reduces. So before I end, very important is nutrition. This is one area which we all ignore. important is that we need to recommend a good 35 to 40 kilocalorie per kg of diet and ensure that patient takes protein. Protein restriction is not recommended. There is a debate between vegetable protein is better than animal protein. Let your patient eat whatever he wants. If possible, yes, vegetable proteins is preferred over animal proteins, but you need to also ensure that while treating such patients, taste and palatability and what the patient is usually eating such kind of diets should be taken into account rather than giving a blanket diet to every patient, which most of your patients are not going to follow. So to conclude, the management of hepatic encephalopathy involves evaluating the cause, rule out other causes, look at precipitating factors, do a specific management. When you're managing such patients, ensure that hepatic encephalopathy management is just one part. You need to treat the patient. Patient has multiple other organ failures which are going on. He may be having an underlying renal disease. You need to take care of that. His etiology is alcohol. Need to take care of alcohol. If he doesn't stop alcohol, there's no point. The medicines what you're going to give are not going to help him. In addition, treat viral causes which are there. Support other organ systems. That's very important. Counseling of such patients is very important. Diet needs to be taken care of. You also need to ensure and give them advice to avoid driving as they may be at increased risk of accident. So with this, I'd like to end here and would be happy to take any questions. Thank you.
Thank you very much, Professor Shalimar, for this very lucid and educative lecture. Now, with that, we have finished all the 4 lectures, and all of them are open to questions and for any discussion. So if any questions have come to the moderators and chairpersons, they can kindly ask the questions to the respective speakers.
Hello, Dr. Malik.
Thank you. Thank you. Yeah.
Miss.
May I ask
So
one?
I could listen to Dr. Shalimar's talk.
Professor Shalimar, that what is the level of serum creatinine, maximum level of serum creatinine, in which we can still use Lola? Because
yeah.
We understand that when raised serum creatinine is there, then we should not use or use it very restrictively.
I think that's a very important question. Is so up to CRAT of 2, urine output when it's good, you can still continue to give Lola. Once it goes above 2, I think you need to be very careful in continuing Lola. You need to consider for alternative measures, and over there probably considering for renal replacement therapies. If there is an indication, then definitely would be of benefit. But still, we do not have real data available right now to recommend CRRT. But yes, that could play a role, and we're looking forward to such kind of data. But creat above 2, I would be very, very careful.
Thank you very much.
Can I ask one question to Dr. Shalimar?
Please go ahead, Dr. Varun.
Come from the audience, you can
Yeah,
ask.
Dr. Shalimar, an interesting point which you made was that polyethylene glycol was compared directly with lactulose.
Correct.
And it results better results. So I just will share my personal experience that sometimes in the ICUs, when the patient comes in HE4, he is obese, 100 kg, it's very difficult to give repeatedly lose any mass and all these things. And sometimes we have tried putting in RT and giving the full PEGLAC dose so that we have a good ball wash. So is it possible that in future that polyethylene glycol, because it is now readily available as it was not before in commercial formulations when lactulose studies came up a decade ago, that it can become at par with the lactulose as a first line therapy for HE? Is it possible?
I think that's a very important point. But one important thing which I would like to highlight, the study which I had quoted has only 25 patients in either group. So one, we need more data before we start generalizing the use of polyethylene glycol. Another important thing what you need to keep in mind is you're using 4 liters of water. The study which I quoted had 4 liters of water in a cirrhotic who's got ascites. Giving 4 liters of water may not be a good thing. You're going to cause a lot of electrolyte imbalances and fluid overload. And these patients may also have renal failure, as Nanda sir said. So it's like initial patients. The patients are really sick. In a stable patient, doesn't have organ failures, PEG definitely can play a role as compared to lactulose for management of overt HE. We need more data for that. Sick patients, I would be very concerned. I would not be giving them 4 liters of water. I may cause more damage or say more dyselectrolytemia, more fluid overload in such patients. So I would be very careful. In a select case-to-case basis, you can consider taking a call if patient is not responding. That would be my take.
Hello, Dr. Shalimar. Just I want to ask, I am Dr. Sidhu.
Yes, sir. Please, sir.
Because normally we disinfect with we give peg wash or peglec in 1 liter water. So can we use 1 liter because the purpose is for disinfection and bowel gut wash. Instead, because for colonoscopy we need to give 4 liter. Because purpose of disinfection for that, usually we in practice we use 1 liter in for disinfection in hepatic encephalopathy. We want to be like do gut wash.
Correct, sir. I would agree with that fact that individual cases we can try, but there is no published evidence right now to say that regarding the 1 liter, 2 liter. But yes, if 4 liters has been shown to be effective, then I believe probably with lower volumes also would be effective. But we need more prospective data on that. On individual case-to-case basis, yes, 1 liter can be tried.
Thank you. Thank you.
Dr. Harpreet wants to ask a question, I think. Sir, you need to unmute yourself.
Okay, yeah. Yeah, Dr. Shalimar. I'm Dr. Harpreet Singh.
Sir, please.
Yeah, we have a patient who comes to us with a recurrent hepatic encephalopathy in almost a pre-coma stage. He's a alcoholic, basically, recently diagnosed to have hepatitis C also. And he stopped drinking about 6 months ago. He's labeled with a fibroscan of E value of 21 and 22. And in the last 2 months, he has been admitted for 5 to 6 times with repeatedly come in grade 3 and grade 4 comas. We have done a CT scan, we have done his abdominal CT also. There's no big shunt which is going across, and the CT head is also normal. Any suggestions? He has been recently started on antiviral treatment also for the last about 1 month, sofosbuvir and velpatasvir.
So, sir, with how about his child status and MELD score? Like, is he a candidate
His child
for
B,
transplant?
child B basically. B is not C.
So,
no CITs.
Okay. And his, so I believe that you've ruled out electrolyte imbalances, you ruled out chronic hyponatremia, his creatinine is all is okay. And
Please,
CT
yes.
head also has been done to rule out any other possible cause for something like he's an alcoholic. Recurrent falls can also sometimes mimic patients presenting as hepatic encephalopathy. Now, CT abdomen has been done, shunts are not there. What we need to do is manage his all etiologies. That is absolute no to alcohol, treat his viral C, what he has. In addition, consider lactulose, rifaximin. The other drugs which are available, which you can consider is something like sodium benzoate. So I believe if his ammonia is high, then you need to target specifically patients ammonia lowering agents, and ammonia lowering agents as I highlighted, and which is available in the market includes lactulose, rifaximin. Lola, oral Lola is also available, though there is a debate whether oral Lola works as compared to IV. Sodium benzoate, so you can combine these. In addition, there is very interesting data now coming up on role of FMT. I'm not sure whether that can be considered, but in a specific setting or case-to-case basis, you can discuss with the patient. And otherwise, definitely, I think transplantation needs to be kept in mind. Recurrent HE is grade 3, grade 4. Each episode is associated, may require intubation and will have risk of infections, and you may lose him. So I would definitely consider option for transplantation, and then
the ammonia level remains around, the ammonia level remains around 55, 60, always.
Sir, I think if ammonia level is normal, you need to rule out other causes. Get a brain evaluation done. Are we missing
And
out
he
something on that?
recovers very fast also. Within 1 or 2 days of hospitalization, it was very fast.
I think we need to go more little deep into the history. Is something precipitating it? Because these kind of episodes
Okay.
is something recovering too quick is also not explainable with the typical hyperammonemic. And if ammonia is
Yeah, we
normal,
had
then ammonia is
something.
not playing a role.
Yeah, we had something in mind. He was taking some sedatives earlier,
Yeah.
but lately we have found out he's not on them also now. And if he has taken some sedative, it will be a little prolonged. He will not recover so fast. The way
Right,
he
sir.
lands up so repeatedly. Yeah, that was another question in our mind. Good. Thank you very much. Very nice. Very crisp lecture. I appreciate always, as usual, your lectures are always very educated.
Thank you, sir.
Dr. Shalimar, this is Dr. Malik from Ludhiana. It was a wonderful, very lucid talk from your side as always. My one question is, someone who presents for hepatic encephalopathy first episode, he recovers, goes on the standard prescription of even lactulose, rifaximin, maybe along with an aspartate. But rifaximin, till how long we need to continue on an outpatient basis? Let's suppose this patient doesn't get another episode of encephalopathy over 3 months or 6 months. So what will be the end point of rifaximin therapy in management of H?
So, sir, if we look at the published data, the NEGM study, which is the combination of lactulose and rifaximin versus the other group, they took it for 6 months. There is other published data for going up to 18 months. Effectively, in clinical practice, you're looking at a lifelong therapy. There is no endpoints to it, whatever we say on terms, because when we know that these episodes occur recurrently, though in absence of published data, we cannot very convincingly say that we can, what is the exact time frame. Published data 18 months, real life practice, it goes on. There is no stopping to it unless the patient gets any side effects, is not tolerating. Definitely we need to keep in mind the chances of resistance, but though this antibiotic has its property of almost like only 5% is absorbed, 95% is not absorbed. So the systemic resistance we're looking at is much less. So I think practically lifelong.
Lifelong. Perfect. And the dose you will keep it as 550 milligrams BID?
So, sir, there is published data on comparisons of 400 milligram TDS versus 500 milligrams BD. No difference. Studies done from the western part of the world shows it to be 550 to be a little more cost effective. So I think available data would suggest we take 550 twice a day is a good dose. But 400 TDS is also good. But as we know that making compliance better, the lesser the number of pills the patient needs to take, the better it is, rather than too many pills, because the patient will tend to forget.
Perfect. Thank you, Dr. Shalimar.
Questions can be asked from other
Any more
candidates also,
questions,
other
Kiran?
speakers also.
Can I can I ask a question from Gaurav? Dr. Gaurav, a very lucid presentation on difficult CBD stones.
Thank you.
I want to ask, what about you described about sphincteroplasty, balloon sphincteroplasty. How safe it is, and up to what diameter of balloon we can go, and what precautions somebody should take before doing, or in what cases we should avoid doing balloon sphincteroplasty?
Very nice question, sir. I think it's very, very important that balloon sphincteroplasty is a very effective modality if used with right indication. So what one has to see is the diameter of the distal CBD. If the distal CBD is strictured or is narrowed, you definitely would not like to go in for a large balloon dilatation. So when I say large balloon dilatation, it is in anything in excess of 10 millimeters. So that is one thing that one should definitely see. Secondly, what I have seen people doing is they try sweeping the stones across the papilla initially, and then the stone would probably get impacted the ampulla, and then they would realize they're not able to pull the stone, and then they would dilate, which is a very risky thing to do. So you would definitely not use a EPPD when you already have a stone in the distal CBD, which can result in a further diameter or a further damage in any this kind of a setting. Thirdly, EPPD is something that we usually do in combination with endoscopic sphincterotomy. So what that does is that, it helps in preventing the impact of the balloon in the pancreatic orifice, decreasing the rate of pancreatitis, and at the same time gives you a very wide opening, enabling taking out of stone. So I personally use it in association with EST. Usually EPBD alone is only in patients who are very old or somebody who has, frank coagulopathy, and never in other cases per se.
Yeah, so that's a very important message. I think that once you have a stone at the lower end of the CBD, we should not try doing balloon sphincteroplasty, because it can lead to formation of pseudodiabeticula or even a CBD rupture or CBD leak, pseudoretroperitoneal leak inside the CBD, which is
one more thing, I think even periampullary diverticulums, that is something one should be very wary of doing a large sphincterotomies. So, when we're doing it with periampullary diverticulum, we probably would just do maybe a 50% or a 40% sphincterotomy and use a balloon sphincteroplasty along with it, rather than just doing a large sphincterotomy alone, which can result in a perforation.
I have a question for Dr. Siddharth. Dr. Siddharth, is the plastic stents out in the era of LAMS in pancreatic fluid collections?
Answer is no. If you are having a good amount of necrotic material and you are able to put more than one plastic stent, it will do the same purpose as the LAMS. Now, if you look at the LAMS versus the plastic stents, if you look at one LAMS versus multiple plastic stents, possibly there is no difference. But one LAMS versus one plastic stent, yes, there is a huge lot of difference.
There is a patient of ours who had a pancreatic fluid collection with the 30% of debris. We put in a LAMS. Patient recovered beautifully, young guy, around 20, 22 years old. We removed the LAMS after, I think, 3 months. Patient asymptomatic. Now the patient had a recurrence of that collection after the removal of the LAMS. Did a ERCP, no definite leak in the PD seen on the MRCP or even the pancreatogram. I even put in a PD stent here. But still that collection is persisting. It's now a large collection, around 12 centimeter in size. So what we'll do in such patients? Put in again LAMS, or we'll put a plastic stent. Now there's no significant debris at present, or put in a plastic stent indefinitely in this patient.
Yeah. See, there are two issues in that. One, that if you are having a recurrent collection, even if you are unable to demonstrate a leak, there definitely is possibly a leak, which is not from the major duct. Yes. It is possibly from one of the peripheral ducts. So putting in a pancreatic stent is possibly mandatory in these patients. And in the second collection, which essentially means recurrence of the previous collection, plastic stent does wonderfully in these subgroup. So once you have put in a plastic stent and the collection is completely drained, and you have already put in a pancreatic stent, then on the other setting you can remove this plastic stent, keeping the pancreatic.
Actually, that collection reoccurred while the PD stent in situ.
Oh, then you cannot remove that stent from the collection.
That has to be left.
To keep it. Yes.
Can I ask one question, Dr. Siddharth?
Yeah.
Sir, actually, there had been a concept that in patients who have disconnected pancreatic duct, plastic stents have to be actually kept forever. And there are studies from Dr. Sham's group and people in West that actually the rates of recurrences are much lesser if you keep a plastic stent and which is draining the upstream pancreas. But however, this large study that's been published from Asian Institute of Gastroenterology in gut lately has actually been, practice changing in the sense that, which say that you can actually take out a metal stent and probably the recurrence would just be a 13%. And if you're talking about recurrences which actually warrant an intervention, would just be 6%. So that would be completely a paradigm change from what we have been practicing. So what do you recommend now and what is your take on that?
So I agree with what AIG has published recently. The issue is that if the collection recurs and it persists, it belongs to that 6% of the subgroup. It does not belong to the 94%, which we normally do. You have drained a collection and things recover on their own. In our own study, which we have published recently, not even a single patient required an pancreatic stenting. But having said that, we do have patients where the collections recur, and then we have to put this stent for lifelong. So we have to make it a tailor-made rather than making a generalized statement that this is to be done when this occurs. So if suppose, for example, I have put in a stent in a pancreatic collection, everything recovers, I have removed the stent, and then it recurs. And especially what Dr. Amit was telling, that PD stent is in situ, then possibly I will leave that forever.
Thank you.
Siddharth, one question. Do after placing the lambs and when we are going to remove the lambs, you will get a pancreatogram either with MRCP in all cases prior to removal? Because there will be a small subset which will disconnected duct syndrome. If we remove the lambs, this patient is going to come back sooner than later with a recurrent collection. So this is a subgroup where when we're removing the lambs, we possibly need to replace it with a plastic stent. Because it's in our practice in 6 months, we've seen 2 cases, did an MRCP before lambs removal, found that actually there was a disconnected duct there. And this disconnected duct was actually communicating with the collection. So what's your view on that?
Right, sir. Because see, the issue is that when we are trying to remove the stent, we at our institute, because we have a free MRI with MRCP in our center, we do it in all the patients. But again, say, for example, you have said that over the last 6 months, only 2 patients had recurred.
Yes.
So it cannot be made a routine practice. If you look at all the Western data, they have not done MRI or MRCP before removing the stent. Since we are already having a trial, I will come up with an answer in a short while. But to our mind, MRI and MRCP is not required in most of the patients.
Only the minority which will recur eventually will need something.
Right, sir.
Okay.
Dr. Alok, can I ask you something?
Yes, sure.
Yeah, sir. So basically, you were talking about, the achallasias, and now everybody is talking about peroral endoscopic myotomy for treatment of achallasias and everything. So now, if you look at the recommendations, what we should not forget is that, they still say that, surgery is a viable option. Endoscopic dilatation is a viable option. So one patient has to be given all the options, especially in patients who have type 1 or type 2 achalasia, where probably a young patient who's probably has a life to go would actually might benefit as much with surgery as with a peroral endoscopic myotomy. However, when you're talking about type 3 achalasia or patients who have distal esophageal spasm, people are talking about using endoflip to decipher the length of myotomy, or probably a poem being slightly superior to maybe even surgical Heller's myotomy. So what's your take on that, those subset of patients with type 3 achalasia?
So as per recommendation from the various groups, those have working on this achalasia, they have recommended long myotomy, especially for the patient with type 3 achalasia and patient with the distal esophageal spasm. So all these group of the patients should be subjected to the POEM rather than Heller's or other things. And for, you very rightly said, for type 1 and type 2, especially young patient type 1, even type 2, their this balloon dilatation is also good result, not as high if we compare with the POEM also. But only if the patient is young, there is no surgical risk or high risk group of the patient is there. So especially the type 3 and those group of patient in which diffuse of spasm is there, POEM has definitely upper edge as compared to the Heller's myotomy and pneumatic balloon dilatation.
But I think now with the changing paradigm, I believe lap Heller's is gradually going a step behind. So POEM, I think with passage of time, another maybe 1, 2, 3 years is going to become the gold standard for treatment of achalasia cardi. So whatever we're going to achieve laparoscopically, anyhow we are able to achieve by endoscopic means. Only I think the risk is the excess risk of reflux, which possibly gets tackled better in a lap Heller's.
I agree, sir, completely, sir. We are offering POEM upfront as a first-line therapy to practically all achalasia.
Now the good thing is, because since we are working in Punjab, so we had one of the best GI surgeons with us for a long time. The people who did a lot of lap Heller's, the day they saw POEM, they said that POEM is the most physiological procedure for achalasia cardi. And they said that the days for lap hallers are actually gone. So I think there is very little doubt, even among the best of the surgeons, that about lap hallers, the days are numbered. It will still stay as one of the rescue options, but POEM is going to be the frontline therapy across type 1, 2, and 3 achalasia.
Dr. Mali, actually, just one more point, that surgeons are very happy the way the endoscopy does a myotomy. The way we take out the longitudinal and circumferential stepwise, it is very difficult for the surgeons to have such long myotomy.
No, even because I will say Dr. Ghosh is the surgeon of GI surgeon of Punjab. He said the beauty by which you see the circular and longitudinal differently, and where you dissect fiber by fiber, this is never possibly surgically. So he said this is how ages, because during lap hallers, they have to do so many things. They have dismantled number of attachments of the G junction, esophagus, do exposure, so many. And they said this is the right way and the technique, and it is the mankind who was missing such a thing for so long. And this is the correct and the most physiological way of actually dissecting and cutting the muscle fibers.
So may I come in?
Yeah.
So we are offering upfront POEM for all type 1 and type 3 achalasias. With type 2, our surgeons are possibly more aggressive, and there is always a fight between us and surgeons. Although we have a very good results with the type 2 achalasia, but still upfront we are offering only for type 1 and type 3.
Why is that? Why type 2 surgery upfront?
Sir, it's not surgery upfront. It is only because of there is a lot of discussion between we and the surgeons, and they always say that we can always do a fundoplication. So the risk of reflux will be much lower as compared to what you do.
Okay.
And we are not doing POEM F as of today. So fundoplication we are not doing. So that possibly is a bit of an inferior thing for us. But yes, if we are able to do, possibly that will also come in our lab.
But even type 2, I think the results of even balloon dilatation will also be very comparable to POEMs. Only thing is the risk of recurrence, but the relief factor will be practically similar in balloon dilatation versus POEM in type 2 achalasia.
We have offered some POEM to a few patients here at PGI. In fact, we have tried even doing a selective myotomy. We're trying to go in from the right side of the perforator muscles, thereby avoiding the sling fibers and preventing reflux. So discussion with experts suggest that POEM is not a procedure to stay. It is not something that is very effective in preventing reflux. The reason being that the degree of wrap is not like what surgeons can actually offer. We've actually seen last case, this just seen a week back, where we had actually attached that wrapped stomach at the myotomy side, and that clip had actually perforated the mucosa and was visible endoscopically. So it's not a very viable option in the long run, and POEM is not a procedure to stay. Maybe alterations, we are already working on that, but POEM is definitely not going to be something that would stand against surgical wrap in the long run.
And secondly, reflux, which we talk about, is more what we see on pH-metry. The clinical reflux or the endoscopic stigmata is less than 10% of the people who undergo POEM. So that still is a very, very small chunk where you have a significant reflux which happens.
Patient is more happy with the relief of dysphagia rather than having a reflux.
Yes.
They rarely complain.
Reflux you can treat with a pill, but dysphagia is something. So people have so much of difficulty.
So shall we come to the end of the lecture session? And we thank all the speakers. Their lectures were of very high quality, and they have done us a great favor for our conference Gastrocon 21. And you all really deserve a great applause from all of us. May God bless you. And we are thankful to you once again. And now we move on to the second session, that is panel discussion on management of Helicobacter pylori infection, which will be moderated by Dr. Nirmalji Singh Malli, who is a very active General Secretary of the Punjab chapter of ISG and ever smiling person. Very nice to talk to always. and he is director of a prestigious gastro center, the AGI Gastro City in Ludhiana. Dr. Malli, please, now you take over and you will be introducing all your panelists, please. Thank you very much.
Thank you, Dr.
I would request
Vijayananda.
the CELTI members to stay if those who are free, please in our panel discussion. I will request all the moderators, chairpersons to stay with us.
Thank you, Dr. Nanda, for such kind words. Your blessings have always been so special since the time I came to practice. One person we always look upon as a senior, great colleague, someone real helping hand, and a very, very gentle and a noble soul. So we always look upon you as the right type of personality to guide each one of us. So we're really indebted to being there, and I think Amit and Alok are really blessed to have your blessings, your love and affection each and every day in working. So really wonderful as a team PG.
Definitely, Dr. Malli. Really, it is really great to work with Dr. Nanda. He's always so inspiring, and he never say no, and he has taught us to always say yes.
We are still learning to say yes.
Yeah. Today I was tired in OPD, but he came and said, "Don't worry, let me see the other patients." Thank you, sir, for today helping out in OPD.
Right. So I think we are just running a little late, but we'll start with the proceedings, which will be a panel discussion. And we have 4 eminent gastroenterologists across 4 different cities of Punjab on board. So I'll start with the first introducing 4 of them. And then maybe, if you allow, I might show 4 or 5 important slides before we actually go on to the discussion part as a part of the panel discussion. So the 4 colleagues which we do have, first, Amitabh Mohan Jarath. The name itself, which spells stardom, I would say. So Amitabh has always been, we've all grown up listening to this name, and when I started first knowing Amitabh, so I was equally impressed with his persona. So great to have you, my dear friend. Again, a wonderful orator. And more importantly, this is one good thing about Amitabh also is the way they started group practice in Amritsar. So this is a commendable thing. They serve with Gastro City. And I personally feel that group practice is the way forward in the years to come. So we're all privileged to have Amitabh in the panel.
Thanks a lot.
Second, we have thank you. Secondly, we have Gursevak. Again, wonderful gastroenterologist, busy guy, soft-spoken from Bathinda. Always pleasure seeing smile on Gursevak's face. And we welcome Gursevak as a part of our panel discussion on Helicobacter pylori. Welcome, Gursevak.
Thank you, dear. Thank you.
And third, Amit himself, the organizing secretary. Again, commendable work you people are doing there in Jalandhar, and always keeping yourself associated with academics, which I think is really, really very important. Year by year, you have made that trend, which I think is really creditable. And now, despite bad times, the COVID times made it opportunity to have a virtual meeting with all of us. And importantly, Amit himself is proactive in all those academic initiatives. So we applaud Amit for whatever you're doing, and we welcome you as a part of this panel discussion.
Thank you, sir. Thank you.
And fourth colleague is someone whose name itself brings smiles on our faces. So if someone the saying goes, if someone in Punjab is feeling low, feeling a little depressed, they say you give a call to Gurbakshish Sidhu and you will feel elated. So Gurbakshish has made that name because of his, again, his persona, his temperament, his extracurricular talent, I would say, along with his academic skill. So you're a worthy panelist for today's discussion on H. pylori. So welcome, Gurbakshish. I think you muted yourself. You need to.
Thank you.
And even you look nice in this beard, and gives a little Bollywood touch to you also, as well as along with Amitabh.
Thank you.
So with these friends, I think if Amit, you allow, can I?
Yeah, sir. Please carry on.
I have to.
It's your show.
It's okay. So, are my slides visible there?
No.
Not yet.
Not yet. Okay.
Not yet.
So I have to share screen.
So
And
there's a
now I
green,
think this will
green
be.
button, sir. Yeah.
Yeah.
Your screen is opening.
Okay.
Yes. Can we go to the
So I
slideshow?
will not be talking anything regarding. It's now seen on the screen.
Yes,
so
sir.
I'll just take 3 minutes. So I'm not talking anything about the management of H. pylori, but specifically now, since we are going into the way the surgeons are going, whether we talk about POEM or third space, whenever surgeons go for a panel discussion, they always give a glimpse of history into that. So I think, which also now as endoscopists and gastroenterologists, we also be doing those things. And for H. pylori, I would say, so we are really indebted to these two guys who actually helped mankind discover these bacteria, which were there possibly since ages, Professor Robin Warren and Barry Marshall. And most importantly, they received Nobel Prize in 2005 in physiology or medicine for discovery of H. pylori. I was actually going in the last 1 week through all the hard work, the relentless effort which these people put up. And this was really, really important to see how over the months to years, they were literally fanatic behind this, that they have to do their job. Robin Warren, which was a histopathologist, is there. And Robin Warren was the first one who challenged that notion. Prior to 1980, the textbook described that stomach is a sterile organ. There is acid, no bacteria can survive. And this, by doing histopathology, they made a major change in our thought process that stomach is no longer a sterile organ. Barry Marshall, who was actually a registrar in the Department of Gastroenterology, he worked shoulder to shoulder, hand to hand with Robin. And then there are a few other guys, the electron microscopy unit head, and then Goodwin, who was a micropathologist there. And then these were initially the two letters which were sent to the editor of Lancet. And 1984 was the first original publication which came about unidentified curved bacilli in stomach in patients of gastritis and peptic ulceration. So this was a landmark publication regarding the discovery of H. pylori. And this, I think, very few people will know. To complete Koch's postulate, which was at that time a mandatory phenomena, that if you say that it is a causative agent, you have to find a person, infect that person, take his biopsies, and prove that there is H. pylori. When no one could come across and come forward for that, it was Barry Marshall himself. Barry actually drank a broth of H. pylori infected patient, got himself infected, day 8 started getting bad gastritis, vomiting, upper abdominal pain, got himself endoscoped, asked Robin Warren to look at his mucosal biopsies. And this mucosal biopsy, which was later on published, was Barry Marshall's own biopsies, and there are multiple H. pylori in his own gastric mucosa. So this is the extent to which these guys go to make a contribution to mankind. And this is when he was awarded a Nobel Prize, the one word which was asked from Barry Marshall to say, he said, it was not myself, it was a teamwork between 4 departments, which was a secret of our first successful culture. And he actually attributed everything to Robin Warren, the electron microscopy unit, and microbiology. So, and the last thing I would just want to bring to everyone's notice, when Warren and Marshall were announced the Nobel Prize for Medicine in 2005, they were physicians doing their daily jobs. They were not chasing Nobel Prize at all. They had no intention to being in limelight. There are no research grants for studying peptic ulcer disease. That happened upon something which they found interesting. They were really hooked onto it. Their commitment, their curiosity, their investigation, and the way reported it, the mankind came to know about H. pylori. So this is just to bring that glimpse of uh, about the history, how the great people have become great, and how the mankind has became so indebted to these people for making these important discoveries, inventions, or innovations. So with these few words, my friends, I'll just stop this presentation here. And I would now, yes, I would now go to the main role which was assigned to me, that is to moderate the session. And I would, I think, first start straight to Amitabh. So Amitabh, my question which will to you would be, what patients should be tested for H. pylori? And do all patients who test positive, either endoscopically or by non-endoscopic means, they need treatment as of 2021? Amitabh.
So, Dr. Mali, thanks first of all for this opportunity to Dr. Singhal, Dr. Sehgal, and Dr. Nanda get us to this podium. So, coming on to the question, patients, when we associate H. pylori treatment or diagnosis, whatever it is, dyspepsia is one group in which we get the patients, and more often than not, the practice is to start them on some medicine or otherwise. But this has been a practice for a long, long time, and we still get patients. Most of them get treated the same way. Once we recognize that H. pylori is a disease, the first question gets answered automatically. That once you understand that H. pylori infection is a disease, which can go on to gastritis, which can go on to adenocarcinoma, which can go on to mold, then the second part of the question gets an automatic answer. Yes, each and everyone who has H. pylori has to be treated. And this is what the current consensus guideline is also, that in today's world, it is no longer that H. pylori has to be associated with some particular findings on endoscopy or otherwise. Each patient with H. pylori, according to current consensus, should be given treatment in one form or other.
Right. And what are the subgroups which you'll be specifically looking for H. pylori in our practice? For example, I would say, what is your take on peptic ulcer disease or other things? All people with peptic ulcer disease, of course, we are going to test. So 1, 2, 3, 4, are there any such subgroups where H. pylori testing as a gastroenterologist is mandatory?
If we look into the basics of the disease, you put it in patients who have dyspepsia of any sort, the symptom associated with that, that is one group. We see, if we talk of the peptic ulcer disease, yes, that is to be checked. Now again, when we are saying peptic ulcer disease, in some ways, once you see peptic ulcer disease, automatically that means you're in, you diagnose something, and it becomes mandatory to test for H. pylori. Same happens for other groups also. Now other groups also come in, even patients with iron deficiency, there's some association that they should also be tested. Then one very important group also becomes a patient who get dyspepsia after a particular age, let's say dyspepsia at late age, which is a sudden appearance, never came. So there are a lot of these groups. Rather, any patient who talks of the upper GI symptoms, according to me, needs to be tested for H. pylori.
Okay, wonderful. Now I shift to Dr. Gursevak. So Gursevak, Amit did hint upon the commonest, I think, upper GI condition which we all come across in practice is basically dyspepsia. And vast majority of our dyspepsia, they are basically functional or non-ulcer dyspepsia. So what is your take on H. pylori testing in people with dyspepsia? Should we testing all or a specific subgroup? And what is the scientific literature? What benefit we are going to derive if we eradicate H. pylori in people suffering from dyspepsia?
So, Nirmal, first of all, thank you, and thank you, Amit and Dr. Nanda and the team for organizing this. So, my opinion or take home from the dyspepsia and H. pylori is that, as you have already shared from the history, that when one of the discoverer took H. pylori and it developed acute symptoms. So there is an association, and there is a subset of dyspepsia patients who are symptomatic because of H. pylori. And as Amitabh has already said, that all patients with dyspeptic should be tested. The issue is not that which which should be tested, which should not be tested. The issue is which method to be tested, because most of us have endoscopies and many of the center don't have other methods to test. So now the issue is the availability of the easy going tests rather than putting endoscopes in so many. As you told, 30% or 40% of our patients are actually dyspeptic. So that will become a big chunk of patients who require testing. The association is very clear, but the issue is that even if we treat H. pylori and dyspepsia, first of all, not all of them benefit. So the number of patients needed to give benefit to one patient is actually various studies between 8 to 14. So you need to treat 8 patients to give benefit to one. And another thing is that the benefit does not come immediately after treatment. So because the gastritis takes few months to settle down, the symptomatic improvement comes later on. And by that time, we lose our patients are lost to follow up. And we don't actually realize whether it has benefited or not. But the point is that, as Amitabh has told, that there is a subset of patients, we know clearly that is this going to cause maltoma? Is this going to cause peptic ulcer? Is it going to cause adenocarcinoma? So for the prevention of these patients, those who test, we have to treat. But there are subset of patients, even after many months of eradication therapy, who do not respond. We call them functional dyspepsia.
Right. So I think the consensus appears to be very clear that we should be testing more often, even in our population of dyspepsia and other conditions for H. pylori. And where H. pylori comes out to be positive, it beyond doubt needs to be treated.
But Dr. Mali, if we see the population prevalence in India, it might be around 70% of the people are probably infected with H. pylori. So anybody having dyspepsia, there is a 70% pre-test probability that he is probably having H. pylori. Whether it is dyspepsia can be due to H. pylori, that may not be due to H. pylori.
Yes.
So that is my reservation about doing H. pylori very frequently in all dyspeptic patients. Only the patients might, in my practice, means I won't do H. pylori in all the patients suffering from dyspepsia. So I will first treat them as conservatively and with the PPI and prokinetics as per the protocol, whether it's a postprandial distress syndrome or EPS. Yeah, and those patients who don't respond and they actually fall into the category of functional dyspepsia, symptoms persisting for more than 6 months, and they're disturbing the quality of life of the patient. And we have tried our level best with our conservative, and then we test H. pylori and treat. Because otherwise, if you test 100 people with functional dyspepsia, I think 70 to 80 will turn out to be positive. And if you give antibiotics, all of them, you know that H. pylori antibiotics are very high-end antibiotics, and they sometimes worsen the patient's symptoms because of the antibiotic-induced side effects.
Especially with amoxicillin.
Yeah. And you are promoting the antibiotic resistance with them also. So yes,
Amit, your point is absolutely well taken, because whatever recommendations we talk about, they have actually originated from the Western world. Either they're coming from US or Europe. Their general population positivity of H. pylori is 10 to 15%.
10 to 15%. Yes.
So in a population where your positivity is very low and you find that positivity a little higher in a subgroup and you treat, you might get a benefit. But where your majority population is already infected, saying this is accounting for that thing is very, very difficult. So possibly for us, H. pylori is more of a friend than a foe. That's how we can put it, because majority of us are actually, even we never know, among all of us sitting here, 10 guys, 7 out of 10 will be H. pylori positive.
Definitely.
So even in my own practice, my own consensus in dyspepsia is I very sparingly use H. pylori therapy. What Amit has hinted, actually once we put them in antibiotics, people tend to come back. So we are even more uneasy now with those number of pill burden, some diarrhea, some change in taste alteration. So those people, rarely they complete a 2-week therapy. But the clear-cut indications, whether it's a peptic ulcer disease, uncomplicated or complicated, gastric or duodenal, you have to test and treat. Early gastric cancers, if you remove it endoscopically, maltomas, So these are beyond doubt indications for actively looking for H. pylori. Dyspepsia still is a huge gray zone. But if you're doing an endoscopy in a dyspepsia, you find some enterogastritis, you find some duodenitis. So in that subgroup, I'm always tempted to look for H. pylori and treat. If it's a totally normal endoscopy, we actually do not test for Helicobacter pylori in these patients.
Dr. Mali,
Your viewpoint?
just one point, Dr. Mali. Actually, in the definition of functional dyspepsia, we have to rule out a structural or any mucosal inflammatory cause to label it as a functional dyspepsia, first of all. The definition of functional dyspepsia as per Rome criteria is a symptom based, 3 to 6 monthly symptom, and how frequently the patient is having symptom. So any patient who has prolonged symptom, if we consider just like epigastric distress pain syndrome not responding to PPI, so issue is that how long we can wait. The only problem is how long we can wait for the H. pylori to be tested to label it as functional dyspepsia. If H. pylori is positive, then we have to treat. Now, the always question, this gray area becomes very difficult for the patient, and when to test also. Already patient on PPI, again testing is a difficult aspect. So before labeling a functional dyspepsia, we have to get an endoscopy done too, to rule out any other structural cause. And if you're doing an endoscopy, then H. pylori has to be tested.
That again, I think, is a pretty gray zone, but that will vary from practitioner to practitioner. But I think still, because what Amit has highlighted is with such a strong general population positivity, even with test, people are going to find it. But how will correlate it with the symptoms patient is? Because a lot of these people will have functional overlay and other factors also. Then attributing purely those symptoms to H. pylori positivity is going to be very difficult.
See, now what we are talking about, the cross between practicality and science. So if today we say that we are not treating those 70%, let's say we're not treating it, then we also don't do it for the sake of science. We say yes, they should be treated. But then in a way, if we come to the other way around, if you were having a magic wand to clear those 70% people of H. pylori, and tomorrow you could decrease the gastric cancer burden in your country, would you do it or not?
But I mean, it's the same issue in the eastern world. There's a very high gastric cancer, because even in Punjab and northern India, we see gastric cancer very sparingly. So despite high H. pylori positivity, our burden for either early gastric or an established gastric cancer is actually low.
My question is that to all the panelists, the question is that we people all are doing endoscopies and taking a rapid urease test. What do you think? Is it 70% positive? Do you 100%. Think it is 70% positive endoscopies? I don't think. The positive patient, they are around 20% or so. I don't know which studies we are talking about, whether our kits are faulty or, but I don't, in my case, I don't know what about you people, but if I do 100 rapid urease tests, I see only 20-25 positive, not 70% positive.
Sir, there are problems with the rapid urease test we do.
Yeah, we are doing after PPIs and other.
We are doing it. Majority of the people we do RUT, they are own PPI. So that is that makes H. pylori very scarce and difficult. Ideally, the PPI should be off at least 2 weeks or ideally 4 weeks. Again, the site from where we are taking RUT is important. We are taking one single biopsy from one single point, say in Caesura. That's probably not indicated. You have to take
4 biopsies.
Yeah, take multiple biopsies from interim, from the greater curvature, lesser curvature, because with time H. pylori ascends to the corpus and it leaves the interim. So, and also the quality of the kits. So all these factors probably change the percentage we see in our practice. But what we can quote is all the epidemiological studies done so far. Agreed. There might be different prevalence in the different era, because there is no epidemiological study from Punjab. There's urban and rural differences also, and the changing hygiene levels, the H. pylori levels changes. So we don't know the recent data, but this is what is there as per the last epidemiological studies from the India.
See, the other end of the spectrum is the PPIs for lifelong PPIs for people. People are so used to take morning capsule that I don't know whether it is required or not. So 20-30% of population is taking it.
They are addicted to it.
But maybe they are H. pylori positive and you could have cured it if you have seen it and given it.
Yeah, that's the point is. So I think we need some better therapies rather than arguing for whether to treat or not treat. Some simpler ways to treat without side effects may not be antibiotics. Something
so
has
what
to do
we'll do
with
is
some.
we'll keep these little loose and still loose only. But we'll move on to Amit for, I think, the next question. Amit, what is now the way, what is the right way in today's era to test for H. pylori? Endoscopic versus non-endoscopic, and endoscopic RUT versus histopathology, and the right way of taking those biopsies. Can you just highlight about that?
Sir, if definitely doing the histology is the gold standard for diagnosing H. pylori. But since doing histology first, it will need an intervention, that is endoscopy. And secondly, the results will be available after few days, depending upon the place to place, up to 4 days to 10 days. So it will delay, there will be delay in the diagnosis. We have an equally good technique of rapid urease test if it is done in a right way with the off antibiotics, off PPI, off bismuth, with a adequate biopsies. As I said earlier, from at least 4 to 5 biopsies from corpus, that is greater curvature, lesser curvature, antrum, and incisura, and doing good kit, using good kit. It has been shown to have an equal sensitivity and specificity to histology, almost more than 90%. So RUT is quite sensitive and specific for diagnosing H. pylori infection. But if we are investigating a patient less than 60 years of age, uninvestigated dyspepsia, like I won't say functional dyspepsia, because as Alok has said, labeling functional dyspepsia, we need to do endoscopy and rule out sexual disorders. A patient less than 60 years, no alarm features, having a dyspepsia which is not improving and patient doesn't want endoscopy, or the endoscopy is ideally not indicated, then doing a non-invasive test like rapid urea breath test, UBT, again it is almost equal sensitivity and specificity as of RUT or histology, but again it has to be done in an appropriate way by off PPI, off antibiotics. We have to take off bismuth. All those things has to be looked into. So for the patients who are not requiring endoscopy, UBT. The patients requiring endoscopy, RUT, with or without histology is the answer. Rest of the things, stool antigen, little inferior, again, more costlier probably than using a UBT. And serology antibody is of no role. H. pylori antibody is of no role.
Perfectly right. So very lucidly answered, Amit. And now we move to Gurbakshish from the diagnostic to the treatment part. So Gurbakshish, someone has come where we've actually diagnosed to be H. pylori positive. Maybe he has underlying peptic ulcer disease. What first line therapy in today's era we are going to offer to that patient? So we have different regimens, a brief about them, and from a practical viewpoint, what in our practice we should be offering this subgroup of patient. Gurbakshish.
Yeah, thank you, sir. Sir, if you see that past era, that from last 30 years, from 1996, if see background, we are using the same protocol. We are using PPI, clarithromycin, and moxicillin, or PPI, moxicillin, and metronidazole. That we are offering. But now we are seeing the change. If we go through the literature, we see that there is a lot of resistance to metronidazole and clarithromycin. Clarithromycin is the main key player. We have to start with clarithromycin, whether patient, what is the geographical area, where is the, what is the clarithromycin resistance. If the, as per data, if resistance is less than 15%, That is the first line treatment. PPI, clarithromycin, and amoxicillin, because that is the choice for that group. But in there is not much Indian data, but I have seen going through one study in Karnataka, South India, that has shown that the resistance to metronidazole is 70%. Resistance of South Indians to levofloxacin, although that is the later on part will be discussed, that is the 50%, and resistance to clarithromycin is 20%. That is in study was done in Kastubra Medical College. That has revealed that the resistance is very high. So more than 20% resistance to clarithromycin. So that should not be now. From last 30 years, the drug we are using is the not ideal first line treatment for H. pylori. So you also must be seeing the patients. I have at least I see that 40 to 50% patients coming to my clinic eradicated H. pylori, coming with recurrence of symptom after 2 to 3 years. The recurrence is so probably now with this treatment, first line of PPA, Clarithro or Moxi, the eradication will be 50% only. So we have to, in that subgroup, we have to see whether Clarithro resistant. We have to see whether patient is metro resistance also. If metro, there is metronidazole resistance also, dual resistance, then we have to offer the bismuth containing quadruple therapy. That is bismuth, PPI, and amoxicillin, either with doxycycline or tetracycline. That should be the first line of treatment for that subset of population who are having dual resistance to clarithromycin and metronidazole. But if the patient is only clarithromycin resistant, metro sensitive, we can offer PPI, amoxicillin. Anyway, Moxi will be there, PPI, Moxi, and metronidazole. And other treatment as first line we should avoid what that is levo and rifabutin should not be, that should be used as salvageable only, because that should be always second line treatment. Another treatment that can be offered other than bismuth containing, like if bismuth is not available, that can be offered is the concomitant therapy, that is PPI, moxicillin, clarithromycin, and metro. All these, this is the non-bismuth containing quadruple therapy that can be offered. These are the two options should be given in our present scenario, where we from last many years the clarithromycin resistance has increased and the metro is also we are resistant. So that should be the first line of treatment if we want to achieve eradication from 80 to 90%. And second, just sir, I want to mention that if we will give, just want to comment that if we will give PPI without eradicating H. pylori, patient is H. pylori dyspepsia, we do not do RUT. We just, like Amit has said, that we sometimes try PPI. Giving PPI in H. pylori positive patient, although maybe having pathologically gastritis, that is also a bad scenario, because giving PPI can lead to hypochlorhydria, and that can lead to progression of gastritis from antrum to corpus. That is where the main problem starts: gastric metaplasia, gastric carcinoma. So giving PPI without eradicating H. pylori is also a bad scenario that we have to pay for. Thank you.
So let's suppose now, Gurbakshish, Monday you go back to your practice. First patient you get is H. pylori. You have to write a prescription now. You have gone through the literature. In Punjab, we don't know about the community clarithromycin or metronidazole resistance. What drugs you are going to write to his prescription?
Sir, because in Punjab, we are not clear whether we are clarithromycin resistant or not. If we will have evidence that we are clarithromycin resistant, then only we will switch to bismuth quadruple therapy. Presently, we are, but as per clinical practice, we are going through the patients of clarithromycin, but we need data from this Punjab belt that we are resistant to clarithromycin. Probably we will be, but ideally we should give the bismuth quadruple therapy, should be the drug option.
Okay. But bismuth still is a huge, I think, problem as far as availability in India is concerned.
Availability is the issue. So yes, that is why I said that in that setting we can use we can use like PPI, amoxicillin along either combination of clarithromycin metro or sequential therapies are also available like doxycycline and amoxicillin. But same sir, presently we are using the same protocol from last almost 3 decades. So that is also a problem. We need to change that also.
I think that
we hope by the time we end, we might be able to make some change the way we are going to treat H. pylori.
Dr. Malli, a small comment. Majority of the preparations available, commercial preparations like pentoside, HP kit, or so, these various kits available, they have an underdose of amoxicillin. They have 750 milligrams of amoxicillin, but the recommended dose is 1 gram. Yeah. So we have to supplement amoxicillin separately, 50 milligrams BD. If you are using a kit preparation, if you're giving separate drugs, it's okay. But if you are using kit, then that point has to be taken. That might be
that becomes 1.5 grams. The recommended dose is 2 grams in 2 divided doses in a day's time.
Yes.
Agreed.
Dr. Mali, coming to what Dr. Sidhu has said. Yeah.
Right.
May I ask one question? Where do they find these Lactobacillus reuteri?
Yes, sir. We'll be coming in the later part of discussion, sir. We'll take up that question also.
Right. Thank you.
We will definitely. Yes,
Dr. Mali,
Amitabh.
with the same what we asked Sidhu, and whatever guidelines are put into place here, where everywhere endoscopy, no endoscopy, this and that. So basically, based on cost in most Western countries, and we know our costs are different from theirs, so our population is also different. So when we say we might change some paradigms by doing all this, should we not now resort to culture to find out what is the resistance pattern in our population? Because it's not too costly compared to what we all give throughout the lives and everything. It might not be worth more than probably 10 days of therapy per se. So 1,000, 1,200, 1,500, whatever the culture costs, at least we could have the antibiotic thing in front of us, most of them. We can find out the right type of antibiotic and start treating in a better way than what we do today.
In the Western world, people are already doing it. So culture is becoming a part of their practice. But I think gradually, this will come to the in our practice as well.
This can be started even tomorrow. This is something which doesn't need anything.
Dr. Amitabh, I don't know exactly, but I think doing culture of H. pylori is not an easy thing. It's not as simple as doing other bacterial cultures where we get a report in 24 hours or 36 hours. I think it needs special media and it takes more time. That's why the culture has never been very popular in the routine practice. So I will further read about it.
Culture, Amit had gone through the culture and sensitivity for H. pylori takes 7 to 10 days. It's a special media. You need a specially designed lab for that. So even things like I think Lal Path Lab and SRL routinely are not doing H. pylori culture. So you need to set up separate labs for those things. But again, we need to inquire. But again, it's time consuming. But yes, we need to know about some sensitivity and resistance pattern in our own population. Because otherwise,
it's a microaerophilic bacteria, not coming into aerobic category, not coming into anaerobic category. It requires a very special kind of media where you can actually grow H. pylori.
Especially in those settings when we are treating second time H. pylori, that time we should start with after culture only. Whether it's 6 times, second time we should always take first culture, then should treat. First time, sometimes you can rely upon that if we know the antibiogram, what is the exactly culture sensitivity of the bacteria. But second time, if patient is resistant, what is the strain, what is the virulence factors? Second time, we should go ahead with after culture only.
I think now we should talk to the Royal Free Hospital at Perth and the Punjab chapter of gastroenterology to set up a collaborative effort of doing culture for all of us, so that we can be even wiser in treating our patients with H. pylori. So I think now we move on, and time already, I think we'll be quickly putting one more set of questions to our panelists. So going back to Amitabh once more, do we confirm eradication in all people where we have offered therapy and they've taken their therapy from whatever duration we have prescribed them, 10 to 14 days? If yes, because now most of the guidelines do say you need to check for eradication, at what time and by what method? So post
now you have to tell me whether we need science or practical thing on this.
Science first, practice later.
So yes, if we recognize, and as we said first, that we recognize, the first thing is recognition, whether we recognize H. pylori as a disease or as Amit said, it is a friendly infection which can stay in us with or without treating. So if it is friendly umami, you don't need to do that. But if going by science or whatever consensus we have as of now, yes, if you started something, you believed in the starting itself that H. pylori is a disease and needs to be treated like any other disease, you have to find an endpoint onto that. Because it's not only that you have to rule out that H. pylori has been wiped out. That is the first part of the thing. That you at least once, maybe 4 to 8 weeks later after stopping PPA, all those things in place, you establish at least for once that this was an intention to treat thing. You treated, you eradicated, and you established that you have done eradication at least once. If tomorrow there is a second time something happens, the person comes again and he wants you to retest, he'll never say that it was not cured in the first place. That is one thing. It is a reinfection. So that would also be established. And 70% population, like Amit says, it's there, and studies say 50% plus many a times. Then there is a very high possibility the person would be infected in his life at least once, twice, thrice, how many times? It can happen multiple times.
And so perfectly agree. So I think eradication, post-eradication testing, ideally, I think it's yes. Guidelines say 4 weeks post-antibiotics and minimum 1 to 2 weeks post-stoppage of PPIs. So one should go for checking of H. pylori. And now going to good sevak, if still the fellow is detected to be H. pylori positive, as Sidhu said, maybe half of them might not get all right with the first course. What second line we have to offer them for eradication of H. pylori?
Well, as Sidhu has already said that for 30 years we are using those formulated kits with inadequate dosing. So most of them are clarithromycin containing, and also the availability of bismuth is sparse. Now, although we have now bismuth available with us, and it is made by one of some Hyderabad-based company, and it's 120 milligram tablet, and we are using it in many of the cases in which it is a recurrent infection or as so. The tablet is 120 milligram, and we are using 2 BD rather than 1 tablet 6 hourly, because it becomes too much of a dosing for next 14 days to the patient. So most of the patients who have already received clarithromycin, the answer is either we give a bismuth-based quadruple therapy, which contains bismuth, PPI, tetracycline, as well as metronidazole, or we give levofloxacin-based therapy. Levofloxacin, amoxicillin, and the PPIs. And the other rare things which are though not preferred or recommended, but they are still in the pipeline, because many of the patients do not tolerate because of some allergies, some reactions, some side effects. So we need to have many more regimens, and one of them is high dose regimen, in which you use PPIs double the dose along with the amoxicillin double the dose. Or you use this thing, concomitant therapy, what we call concomitant therapy, that rather than 2 antibiotics, you add third one also. You add metronidazole or tetracycline. So these are the things which, and other things are, though not much data about other probiotics or prebiotics, but they are still in the pipeline.
Sandwich has to be practically a quadruple therapy, either bismuth-based or even a levofloxacin-based therapy, at least if you're looking at the triple therapy in that.
Yeah, at least 14 days therapy is important in this.
So quickly now going back to Amit, any other promising combos or drug formulations in pipeline which we feel will change the treatment guidelines in the next 1 to 3 years, Amit?
Sir, I won't say there is very promising anything available so far, which is going to change the things. But using high potency PPI, like vonoprazone, which is not available in India so far, it's available only in Japan, with high acid suppression, and has been shown to increase the efficacy of whatever antibiotics you are using along with it. So that is one of the things that you use high potency PPI. Then adding like where the no antibiotic is using people have used rifabutin based therapies, which I don't know. Again, there is a chances of, if you use rifabutin, again in India is in endemic zone of tuberculosis, how we are going to see it in that way, that we are increasing the tuberculosis resistance. So, but I won't say there are any promising newer antibiotics, cross-link for antibiotics available. Only important thing which I could find in the literature was a vonoprazole, which is vonoprazole, which is a high potency PPI.
Okay. So again, I think totally agree. So two studies in one in 2019 and one in 2020, both came from China. So there, what the point you said, they have endorsed rifabutin as a good drug in H. pylori. Both had a 14-day therapy, amoxicillin, rifabutin, along with PPI, almost 85% eradication rate, close to 85%. They're both, one is 83, other is 86, something like that, coming both from China. So, but not much of data from the Western world, but we might see rifabutin as a key player, maybe in next 1, 2, or 3 years. So, but still, Western, although FDA, after these Chinese studies last year, has approved rifabutin as a salvage therapy for treatment of H. pylori in combination of amoxicillin and PPIs. Gulbakshish, to you, what even Dr. Nanda also is very much interested. So there's a lot of pharma pressure coming from Lactobacillus reuteri, Pyloflush, 1 or 2 more brands coming. Guidelines nowhere mention about that. What is your take? Is there real hope in a bacteria flushing the other bacteria, or it is just a hype?
So the lactobacillus, because it has been the only unique feature of this probiotic is lactobacillus reuteri, because it can bear with the harsh conditions of stomach. That is why it got advantage over the other probiotics, because other probiotics get weakened when goes into acidic environment. So that is the reason that these studies came with this, but the data is very weak. And there is data that if we see it's the role is only as adjuvant therapy. So we are hope only for adjuvant, because it decreases the H. pylori load, like we used to use the ribavirin to decrease the H. pylori with drugs. So it decreases the H. pylori load, but cannot eradicate. So if we see that probiotic can eradicate, that is the just hype. But if we use the adjuvant, it can increase the eradication rate by decreasing side effects, by dealing because otherwise we see a lot of problems with clarithromycin, moxicillin, loose stool, diarrhea, abdominal cramps. So that reduces if we use the probiotic, the lactobacillus reuteri, and it so indirectly it increases compliance and it decreases H. pylori overload. And so that is the reason it can be maybe useful in near future for increasing the eradication rate of antibiotics we will use for the H. pylori. Another antibiotics that maybe that Abhin has mentioned, that I don't know how many, that nitazoxanide, have you any because that is also one drug that is upcoming for H. pylori. So there is limited data that nitazoxanide also may work for that may be included in near future for eradication of H. pylori.
Okay. Wonderful, Gulbakshish. I think with that, we have come to some consensus. I would say that we all are very clear, I think, for some of the audience whosoever would have logged on, that there are definite discrete indications where H. pylori needs to be tested, whether it's peptic ulcer disease, early gastric cancer, or multiple lymphoma. Dyspepsia, I think still, I will say the fingers are very much crossed in Indian population, where we should draw a line. Therapy, we're very clear that resistance is cropping up very fast. Triple therapy might not be the best suitable option for all patients as a first line. We might be switching over to quadruple or the newer therapies. Lactobacillus reuteri, maybe as an adjuvant, may appear to have some role in the times to come. But if you give eradication therapy, important to test for these patients 4 to 6 weeks post-treatment to look for eradication. So I think this is where we are. And Amit, any?
Yeah, I think there are many physicians probably who have logged in and listening to us.
Right.
I've seen many prescriptions of physicians, even gastros, of having H. pylori prescription without even testing H. pylori in a patients with dyspepsia or upper GI symptoms. So I would try to discourage that practice, that we should at least test H. pylori and then treat. Test and treat is okay, but but without testing, writing H. pylori treatment, that too suboptimal, as we say that the kids are suboptimal dosage, we are probably going to increase the resistance further and making our lives more difficult. So anybody who is suspicious, not improving, you think that it can be H. pylori, yes, do test it. And even if you don't want, the patient don't want endoscopy, non-invasive urea breath test is as good as, and good sensitivity. With the only problem is that you have to keep patient off PPI, or even if you do on PPI and it comes out to be positive, it is specific, it is true positive. But patient is on PPI, test comes negative, you might need to test it again after keeping the patient on H2 blockers. You can keep the patient on H2 blockers and repeat it after 2 to 3 weeks. So that is that I would say that is important.
Stool antigen test is available here? Or
Lal Path Lab is doing.
Yeah.
Lab Path is doing.
But the problem of antibiotics, PPI remains with any test. There is no test which can, even if whether you do use antigen, whether you use RUT, whether you do histology, in all the tests, that is a limitation.
But because it decreases the bacterial load, when bacterial load decreases, the test will come falsely negative, because all PPI reduces the bacterial overload.
Yes.
So when load decreases, UBT will be affected, stool antigen will be affected, so it will come falsely negative. So the problem with all these is same.
I think take home would be that we start using again famotidine or netidine for 2 weeks at least, in though not very sick but dyspeptic patients with the before diagnostic endoscopy.
Yeah. Yes.
At least 2 to 3 weeks, and then do endoscopy or biopsy. At least we will be reassured that the prevalence is now right.
Yes, and we should take multiple biopsies while using RUT.
Dr. Gosevak, reading the kit after some time is also something, it changes the time. So if you read it over a bigger length of time, the positivity would increase.
I was listening to a lecture from Dr. Usha, PGI. She said that she waits till 24 hours.
Yeah.
Even if the color changes after 24 hours, they consider it to be positive. So I don't think we'd all of anyone wait for 24 hours. Even if the test initially comes negative in next 5, 10, 15 minutes. So that was a new thing I learned from her.
If you see the endoscopy room, we discard those kits after 24 hours only. So we just look the first reading at 30 minutes, second even at 4 hours, and at 24 hours. Negative by 24 hours is truly RUT negative. So I think it should not be discarded immediately the next day, which is I think many of the centers are following that policy, and which is the right policy.
Which test kit should be? There are 2 types of rapid urea tests available. One is the well type, other is the test tube type, other is the freshly made solution, which we were doing during our training in the institute. So what do we think? Which one is the better one? Some are pylo dry kind of tip. They're really dry. I don't know whether enzyme acts on that or not. There are some which are in the gel form. And the other one, third one is the liquid one. Any experience on that?
We are using the well type only. So over the years,
I have used the liquid type, well type, and the freshly made we used in the institutes only.
Right.
But I think if the material is good, that adequately made, then the efficacy or the sensitivity remains the same. Only if that the coating urea which you need to impregnate, and a color indicator, pH indicator, which has to be there in that kit, is not that adequate, then you definitely you won't get a good result.
So in those small slides which are available in most of the vendors, you can't put 4 pieces of tissue on that.
You can.
Okay.
One is very small. Then there might be a problem. But standard well type we use with a slide, with a standard slide and a well made onto it. There you can put four pieces easily.
4 pieces.
Yeah.
But good Sevak, I mean, surprisingly, I believe 200 kilometers away from our place, probably the prevalence dips in Bathinda. We almost get every patient as positive. We see hardly any negatives if you ask.
There must be difference with the kids. There must be difference with the kids.
Positive. Maybe.
ਇਹਦਾ ਪਾਣੀ ਦਾ ਫਰਕ ਹੈਗਾ ਜੀ
ਅਸੀਂ ਪੀਪੀਏ ਖਵਾ
I
ਕੇ
don't know
ਕਰਦੇ
about
ਹਾਂ, ਤੁਸੀਂ
Malli
ਪਹਿਲੇ
and
ਕਰ ਦਿੰਦੇ ਹੋ।
Amit and all, but I think 70% positivity definitely comes in these kids for sure.
Okay.
Plus, in a way, patient selection is also, I mean, whatever I might do or say, I mean, you don't do an endoscopy out of an OPD of 100, you might do it on 2 or 3. So if you see, out of them, you've already selected patients who have not responded, this and that or whatever. So in that, if 60-70%
many confounding factors there.
Yeah.
So we had a wonderful discussion. I think Amit, you and Dr. Nanda wish to say something. Otherwise, I think we are already 20 minutes past 9 now.
I think we had a wonderful time, and it was wonderful to be connected once again after such a long gap of COVID. And I thank you all for joining us. And it was rather a meet for all of us as a Punjab chapter of IST. And we wish to organize and participate in many more such events in the near future, and seeking active participation from all of you. And thanks from the core of our heart, from the team of Dr. Nanda, Dr. Alok, and that you have given us a chance and given us a time from your busy schedule. Thanks to Dr. Malli, Dr. Gursevak, Dr. Amitabh, Sidhu. Dr. Harpreet has been very kind to join us and give us blessings and worthy comments. All our faculty members, Dr. Siddharth, Dr. Gaurav, Dr. Shalimar. I'm fortunate that Siddharth as well as Shalimar was my juniors in All India, and they were readily agreeing to give the lectures, whatever I said. Gaurav is also a dear friend and junior. So it's a pleasure that we had everybody on the board today, and it gave us to refresh. I mean, I learned, though we treat H. pylori, but it gives us a chance to read about it. And definitely once we read and we knew lot many things, and it tends to improve our practice. So that's the biggest advantage I feel of having these kind of discussions. We can know the theoretical aspect as well as the practical aspect, how we can improve ourselves. So I thanks once again to all of you from the core of my heart.
Thank you so very much. We all are very much privileged to be part of this occasion.
Thank you very much.
Thank you, Dr. Malli.
Thank you, sir.
Thanks a lot.
It is fortunate to hear from Dr. Gurgashish after a long time. Yes, Dr. Malli.
I think Dr. Harpreet is still with us. Dr. Harpreet,
Harpreet, sir, please unmute yourself, sir. Please unmute
hello.
yourself.
Hello.
Any final words of wisdom from your side?
No, I want to just congratulate again Dr. Nanda and his team for a wonderful this exercise, and they have been able to fetch the best of the the faculty members from all over the northern India to give us these latest developments in these topics of acute pancreatitis, hepatic encephalopathy, and H. pylori. Thank you once again. I think I want to congratulate. I think we should have more and more sittings like this from other cities as well. We hope other cities will also do the same, effort to develop these lectures.
Absolutely.
Thank you very much. Thank you.
Sure. Absolutely. I think, thank you so much. Not able to see Amit right now, Amit and Dr. Nanda, but I think good night, and we had a wonderful session.
Good night, sir.
Have a great weekend.
Thank you, Dr. Malli. Thank you once again, Dr. Malli, Dr. Sidhu, and Dr. Gursevak, Amitabh. Really nice to see you all once again. Good night.
Okay.